Okay. Hello everyone. Welcome to the session, guys. Please let me know if I'm clearly audible and visible. Okay, today we are going to do dermatology. Why dermatology is important, guys? Because it connects with other subjects like microbiology. You have seen like with PSM and pediatrics. Okay, so it is very important to understand to make integrated connection between these subjects. Okay. Okay. Yeah. Good evening, guys. Good evening, Rishi. Good evening, Varun. Okay, guys. So it is very important to understand this subject because this is going to help you in the other subject as well, right? So without any further delay, I think we should start now. Dermatology, right? So we are going to cover up the most of the topics. First one is your basics of dermatology. We will study with the basics. Then we will study about the skin appendages. Then we will study about the papillosquamous disorders like psoriasis, lichen planus. Okay. Then we will go to infections. What are the different kind of infections that we are having? For example, let's say bacterial infection, viral, fungal, and your parasitic infections. Okay. Then we will be studying about the STDs and all those genital ulcers. Okay. And then we will be moving to vesicobular disorders, and ultimately we are going to pigmentary disorders, and I end up with the some miscellaneous topics, right? So we are going to start with the basics. Okay, if you have done your dermatology, well and good, it will be good for revision purpose. But if you have not done your dermatology before, then also it will be helpful for you. So please guys, just be with me till the end of the session, and we are going to do everything. We are having all the PYQs included in the session, right? So without any further delay, let's start with the session. First thing is your anatomy of the skin. Okay, so can anyone tell me, just try to be interactive, can anyone tell me which is the largest organ of the skin, largest organ of the body? That is your skin. Okay, so skin is the largest organ of body, right? What is the weight of the skin? How much does it weigh? Remember, it is 4 to 5 kg. And what is the area that is covered by the skin? That is your 1.73 to 2 meters square, depending on the person to person, right? So these are the basic things. Okay, now we are going to talk about the layers of skin. What are the layers of skin? You have seen skin. What are the different layers in your skin? Okay, so the outermost layer is your, remember, the outermost layer is your epidermis. Okay, between epidermis and dermis there is another layer that is known as basement membrane zone. Okay, then there will be dermis, and then there will be hypodermis. Okay, so we are having three layers. Basically we are having three layers. The outermost is epidermis, then there will be dermis, and then there will be hypodermis. Okay, epidermis is outermost layer. Basement membrane zone, also known as dermo-epidermal junction. That means it is between the dermis and epidermis. Okay, so these are the basic layers. This is your epidermis, this one is your dermis, and this one is your subcutaneous tissue. Remember, hypodermis is also known as subcutis or subcutaneous. Okay, so these are the layers that you should know. Okay, now let's talk about the layers of epidermis. Epidermis is further divided into different layers. Okay, so we can remember it with the help of a mnemonic, right? So the mnemonic is, come, let's grab some burger. Okay, let's grab some burger. Okay, so first one is your stratum. Remember, the meaning of stratum is layer. Okay, the meaning of stratum is layer. So first one is your stratum corneum. First one is your stratum corneum. Then second one is your stratum lucidum. Stratum lucidum. Third one, G for stratum granulosum. Stratum granulosum. Okay, next one is your stratum spinosum. Stratum spinosum. And the last one is your deeper layer, deepest layer is stratum basal. Okay, it is present in the base, so it is stratum basal. You can look here. This is your skin. What we have seen, skin has three layers. Outermost is epidermis, second one is dermis, third one is hypodermis, right? So first one layer, now we are opening the first layer, that is your epidermis. First thing is your stratum corneum. Look here, this is your stratum corneum, then stratum lucidum, then stratum granulosum, then the next one is stratum spinosum, and the last one is your stratum basal, right? There are multiple kind of cells that are present in these layers. Okay, so let's talk about the cells of the layers, right? So first thing, what are the different kind of cells that are present in your epidermis? Okay, what are the different kind of cells that are present in your epidermis? Look here, this one is your keratinocytes. Okay, keratinocytes. This one is your melanocytes. Okay, melanocytes. We will talk about the function of these cells. This one is your Merkel cells. Okay, one more is there, that is your Langerhans cells. Okay, let's talk one by one about them. First one is your keratinocytes. Okay, what is the function of keratinocytes? What are keratinocytes? They are the most abundant cell. Remember guys, these are the most abundant cells. These are the most abundant cells. Okay, they are present in all the layers, all the layers of epidermis. They are present in all the layers of epidermis. Okay, remember there was a question from where the keratinocytes are derived. So they are derived from, anyone answer in the comment section. Answer in the comment section. Till we then we talk about melanocyte. Till we talk about melanocyte, tell me that keratinocytes are developed from which layer. Okay, let's talk about melanocytes. Melanocytes, नाम से ही पता चल रहा है. What do you understand by melanocytes? They will be secreting, their function is they will be secreting melanosomes. Okay, and that melanosomes will be giving rise to melanin. Okay, can anyone tell me what is the function of melanin? How many types of melanin do we have? We are having two types of melanin. Remember, we are having two types of melanin. First one is your eumelanin. First one is your eumelanin, and second one is your pheomelanin. Second one is your pheomelanin. All right, that eumelanin will give rise to black color, and pheomelanin will give rise to white color. Okay, that is the function of melanin. Okay, these melanocytes are dendritic cells. What is happening? Look here guys, these are your melanosomes. These are your melanosomes. Okay, these are coming from stratum basal. Melanocytes are present in which layer? Stratum basal. They are present in stratum basal. Look here, we have seen melanocytes are present in stratum basal. What will happen? They will secrete melanosomes, and those melanosomes, they will go to keratinocytes, and they will impart the color of the person. Okay, they will give the color to the person, right? Melanin will give the color to the person. Okay, so this is your melanocyte. Okay, and this and remember one more thing, one more question from here is that what is epidermal melanin unit? What is epidermal melanin unit? Look here guys, there are multiple melanocytes. Okay, melanocytes will be giving melanosomes, and those melanosomes will be giving melanin, and melanin will impart color, right? So one melanocyte will be giving color to how many keratinocytes? That is, one melanocyte will be giving color to 36 keratinocytes. Okay, 36 keratinocytes, and this is known as epidermal melanin unit. What do we call it? This is known as epidermal melanin unit. Remember, this was the question asked. That is, one melanocyte will be giving rise to how many keratinocytes? That is 36 keratinocytes, right? Moving on to next is your Langerhans cells. Okay, let's see if you have answered. Okay, very nice. Serotonin, very nice. Okay, keratinocytes are derived from which layer, guys? They are derived from ectoderm. They are derived from ectoderm. Same here, melanocytes are derived from which cells? Melanocytes are derived from which layer? Answer me. Okay. Next one is your Langerhans cells. Langerhans cells. Okay. Langerhans cells are the third thing. Answer in the comment section, guys. Melanocytes are derived from which cells? Okay. Third one is your Langerhans cells. Langerhans cells, they are present in stratum spinosum. They are present in stratum spinosum. Spine means spinosum is also known as prickle cell layer. Okay, prickle cell layer. I will tell you how. Okay, they are present in stratum spinosum. They are basically antigen presenting cells. They are basically antigen presenting cells, and they are phagocytic in nature. How they are? They are phagocytic in nature. This is very important. There is a disorder that is known as Langerhans cell histiocytosis. Okay, Langerhans cell histiocytosis में क्या होगा? There will be increase in the level, increase in the number of Langerhans cells. How we will check? We will see some markers. Okay, what are the hallmarks? This was the question asked. This was the question asked. What is this, guys? Can you answer? What is this? Okay, very nice, very nice. Okay, so they are basically Langerhans cells are derived from. ये भी बताओ, Langerhans cells are derived from which cell, which layer? Okay, you know, Langerhans cells are derived from, they are phagocytic in nature, so they are derived from bone marrow, right? So it can be mesodermal in origin. Okay, origin पे question है, that is your mesodermal in origin. What is the hallmark? Hallmark is your tennis racket appearance, and Birbeck granules. These are your Birbeck granules. What is this structure? This is electron microscopy, and this is your tennis racket appearance, and these are known as Birbeck granules. Okay, this is the marker for Langerhans cell histiocytosis. Okay, let's talk about some gene marker, that is CD1A, CD207 and S100. Okay, these are the basic markers for Langerhans cell histiocytosis. These are the basic markers for Langerhans cell histiocytosis. Okay, the fourth cell that we are going to study about is your Merkel cells. Okay, Merkel cells. Merkel cells are basically, they are touch receptor. What are they? They are touch receptor. These are your type 1 slow adapting touch receptor. Okay, slow adapting touch receptor. They are present in stratum basal. कहाँ पर होंगे Merkel cell? They are present in stratum basal. Okay, one more thing is there from physio, that is your stratum, that is your Meissner's corpuscles. Meissner's corpuscles, remember Meissner's corpuscles are present in which layer? Dermis. Okay, in epidermis we are having Merkel cells. Okay, in epidermis we are having Merkel cells. They are derived from, again, they are derived from ectoderm. Okay, they are derived from ectoderm. Okay, all right, let's see if you have answered. Very nice, Subba Reddy, very nice. Schizophrenia, very nice. Okay, so these are present in, melanocytes are coming from neural crest cells. These are derived from neural crest cells. Okay, moving on to next, let's talk about the layers. What we have studied till now, we have seen the three layers. First one is your epidermis, second one is your dermis, third one is your hypodermis. We have seen in epidermis we are having basically 5 layers that we have seen. These are, okay, these are your 5 layers that we have seen, and there are 4 kind of cells. First one is your keratinocytes, those are most abundant cells. Second, we have seen about the melanocytes. Melanocytes, the function समझ में आया, what is the function of melanocytes. Third thing is your Langerhans cells. Langerhans cells are antigen presenting cells. Function समझ में आया, Birbeck granule is very important. Then we have seen about the Merkel cells. Merkel cells are present in epidermis. Remember from physiology, Merkel cells are present in epidermis, while Meissner's corpuscles are present in dermis. Okay, they are derived from ectoderm again. Okay, let's talk about the layer one by one. We will, because nowadays questions are coming from histology, so histopatho part तो समझ में आना चाहिए from where it is coming, right? So first thing, stratum corneum, that is your stratum corneum. Remember guys, look here, these are the dead keratinocytes. Okay, from stratum basal, these are your columnar cells, they are having nucleus, but in stratum corneum there is loss of nucleus. First thing, that is there is loss of nucleus as the cell is going upward, right? Second thing is the cell is becoming flattened, right? Look here, these are your columnar cells, but in the stratum corneum there are flat cells. Okay, these are your flat cells. Let's talk one by one about each layers. Okay, so this one is your stratum corneum, this one is your stratum lucidum. Remember, stratum lucidum is a clear cell layer. Okay, clear cell layer कहाँ present होती है? Where do you find stratum lucidum? In the palm and soles. Okay, in the palm and soles. Third thing is your stratum granulosum. Look here, नाम में ही लिखा है, it is written granulosum, so there must be granules, right? So these are the granules that are present. Okay, we will talk about what kind of granules they are. Next one is your stratum spinosum. Look here, these are the spine, these are the spine. Okay, that is why it is also known as prickle cell layer. What do we call it? Prickle cell layer. Okay, and the last one is your stratum basal. Okay, last one is your stratum basal. Look here guys, this is the histology. Did you see any nucleus here? No. So that is your stratum corneum, devoid of nucleus. Stratum corneum is devoid of nucleus. Second layer is your clear cell layer. Look here guys, this is your clear cell layer, that is stratum lucidum. Clear cell कौन सा हो गया? Stratum lucidum. Third one is your stratum granulosum. Third one is your stratum granulosum हो गया, ठीक है? And next one is your stratum spinosum. यहाँ पर क्या है? What do you see? You are looking for granules. Okay. Next one, here we are seeing some spines. Okay, what are these spines? I will tell you. Two keratinocytes. Look here, what are these spines? Look here, these two keratinocytes, they are bind together with the help of a protein. What do we call it? Write in the comment section guys, what do we call it? What do we call these proteins that are adhering to cells? These are known as desmosomes. क्या बोलेंगे इनको? What do we call it? These are your desmosomes. Okay, so because of these desmosomes, this cell layer will look like spinous. Okay, because of this. Next one is your stratum basal. This one is your stratum basal. These are your columnar cells. All right, and then there will be basement membrane zone, or we can say dermo-epidermal junction, and the last one will be again dermis. Okay, so these are the layers of epidermis. Then there will be dermis. Right. Two important things we have to look for. First thing is your dermal papilla. Second thing is your rete ridges. Okay, two things we need to understand. One is dermal papilla, another one is rete ridges. तो dermal papilla क्या होगा और rete ridges क्या होंगे? Okay, so the part of, we can remember like that, the part of epidermis which is invaginating into the dermis. Okay, this is the part of epidermis. This is the part of epidermis which is invaginating into the dermis, right? So this part is known as rete ridges. This part is known as rete ridges. The part of epidermis which is going inside to the dermis, that is known as rete ridges. Okay, second one is your dermal papilla. What is dermal papilla? Look here guys, the part of dermis that is invaginating into the epidermis. All right, so this is the part of, look here, this is the part of dermis. This is going into the epidermis, right? That is known as dermal papilla. All right, so these two terms you should remember. Okay, are we clear till now? Okay, let's move. Let's talk about one layer. Okay, so the first one layer is stratum corneum, right? The uppermost layer that we have seen, that is your stratum corneum. One thing that we know, first thing is they are flat cells and devoid of nucleus. There is no nucleus, right? There is no nucleus. Second thing, how these cell layers will grow? They are grow from the base to the top, from the basal to the corneum. They will grow like that. Okay, so there will be no nucleus, and they will be absent in low birth weight babies or preterm babies. Okay, this is very important. Whenever there is a preterm baby, how you will identify? You will look for the stratum corneum. The stratum corneum is generally absent in the preterm babies, right? Because it is devoid of, because of the this reason, right? What will happen? The stratum basal, the cell will grow and it will be going upward. Okay, but this is the topmost layer, right? This is the topmost layer. Whenever this one is your stratum basal and this one is your stratum corneum. Okay, so there will be a thing that is known as epidermal transit time. This time is known as epidermal transit time. Okay, this is known as epidermal transit time. What will happen? The cell, the keratinocytes will grow in the stratum basal and they will be moving to the stratum corneum, right? So this is the thing. Next thing is your stratum lucidum. Stratum lucidum is also known as clear cell layer. Okay, why this is clear cell layer? Due to presence of elidin granules. Okay, elidin granules are there that will lead to clear cell layer. They are present in your palms and soles. Okay, they are present in your palm and soles. You can remember like that, palm and soles, only present in your palm and soles. Lucidum में L आ रहा है. Here also we are having in palm and soles, we are also having L. Okay, next layer is your stratum granulosum. Remember stratum granulosum, we are having multiple granules, right? So that is your stratum granulosum. In stratum granulosum we are having two things. First thing is your granules are present. First thing is your keratohyaline granules. कौन से granules होंगे? Keratohyaline granules. Okay, what is the function of keratohyaline granules? They will produce a protein that is known as profilagrin. Profilagrin. There is a connection problem. Just a minute, guys. All right. I think it's working now. Okay. Profilagrin will be converted to filagrin, right? And what is the function of filagrin? The function of filagrin is filamentous aggregating protein. These are filamentous aggregating protein. If there is loss of keratohyaline granules, then there is a disease will occur that is known as ichthyosis vulgaris. Ichthyosis vulgaris. Remember guys, if ichthyosis vulgaris is due to deficiency of keratohyaline granules. If there is no keratohyaline granules, there will be ichthyosis vulgaris. Okay, and atopic dermatitis can also occur, right? Second thing is your membrane coating granules. कौन से होंगे? Second thing is your membrane coating granules. What is their function? They are also known as Odland bodies. What do we call? Odland bodies or lamellar bodies. They are also called Odland bodies or lamellar bodies. Okay, the function of Odland body and lamellar body is to generate lipids, right? The function is to generate lipids, and if there is decreased amount of lipid, what will happen? There will be dryness. अगर lipid कम होगा, if there will be decreased amount of lipid, what will happen? There will be dryness, and due to that dryness, what will happen? There is a disease that will occur that is known as winter eczema. Eczema मतलब dermatitis एक तरीके से. Eczema is the dermatitis. So there will be winter eczema, also known as astiotic eczema. Astiotic eczema. Right? So there will be eczema over here. You can see. Okay, that is due to dryness, right? Because there is loss of membrane coating granules. Okay, so two things that we have seen. First one is your keratohyaline granules. Second one is your membrane coating granules. They are present in stratum granulosum. Moving on to next is your stratum spinosum. Stratum spinosum, also known as prickle cell layer. I have told you because there are keratinocytes. There are keratinocytes which are bind together with the help of desmosomes. किसकी वजह से जुड़ेंगे ये? That is due to the help of desmosomes. Okay, there are multiple kind of desmosomes. We can write it here. There are desmoglin, desmocolin, desmoplakin, plecoglobin. These are the adherent. Their function is to adhere to keratinocytes. Function क्या होगा? The function is to adhere to keratinocytes together, right? This is the function of desmosomes. Okay, next one, let's talk about stratum basal. Okay, next one is your stratum basal. In stratum basal, there are maximum keratinocytes. I have told you the keratinocytes are generating in the stratum basal and then they are moving upward. Okay, that is known as epidermal turnover time. I have told you this is epidermal turnover time. How much time it will take? It is approximately 56 days average. This is a question asked. The range is 52 to 75 days, right? There are two things. First thing is your epidermal transit time. Then what will happen? The cells will go to stratum corneum and then they will shed off. Okay, so first thing will be, this is your stratum basal. What will happen? The cell will go to stratum corneum, keratinocyte will go to stratum corneum, and then what will happen? It will shed off. Okay, how much time it will take? It will take 28 days to reach the stratum corneum and then again 28 days to shed off, right? So this is your stratum basal. So till now we have seen the we have seen the five layers. We have seen the 5 layers, right? Okay, so these are the layers of the cell. In psoriasis, right? In psoriasis, it will take 4 days, right? It will take, epidermal turnover time will be 4 days in psoriasis. Okay, let's talk about some disorders. The first disorder that we are going to study about is parakeratosis. Okay, what is the meaning of parakeratosis? The meaning of parakeratosis is there will be presence of nucleus. There will be presence of nucleus in stratum corneum. There will be presence of nucleus in the stratum corneum. Okay, how we can remember? What are the examples? With the help of a mnemonic, that is your P's. Okay, in which condition we can see parakeratosis? Parakeratosis कहाँ मिलेगा? First thing is your psoriasis. Okay, psoriasis. Second one is your eczema. In eczema. Third thing is your actinic keratosis. Fourth thing is a seborrheic dermatitis. And the last one is your squamous cell carcinoma. These are the conditions where we can see parakeratosis. What is the meaning of parakeratosis? Important hai. Remember guys, the meaning of parakeratosis is the retention of the nucleus in the stratum corneum. Okay, stratum corneum layer. Okay, second thing is your dyskeratosis. What is the meaning of dyskeratosis? Dyskeratosis means the abnormal keratinization. Okay, abnormal keratinization. Where do you see abnormal keratinization? In benign diseases like Hailey-Hailey, Diarrhea disease. In pre-malignant conditions like Bowen's disease. You can also see it in malignant conditions like squamous cell carcinoma, right? Till now we have seen about the two things. Next thing is your acantholysis. What is the meaning of acantholysis? Acantholysis का मतलब क्या होगा guys? आंसर करते जाओ जहाँ पर भी हो, wherever you are, just try to speak with me so that you can remember for longer period of time. Okay, so just try to answer with me. All right, very good. Acantholysis. The meaning of acantholysis means is the separation of keratinocytes. The meaning of acantholysis is separation of keratinocytes. Okay, here what will happen? Look here guys, this is a keratinocyte. Both of them are binded together with the help of desmosomes. Now what will happen? If this desmosome is broken, right? If it is broken, what will happen? These cells will be free. So these free keratinocytes, these are known as acanthocytes. Okay, these are known as acanthocytes, or this is known as acantholytic cells. Okay, how we will see whether the cells are free? We will see in the Zinc smear. Look here guys, these are your free acanthocytes. Okay, generally what should be happening here? They should be connected with another cell. Okay, in stratum spinosum they should be connected with the another keratinocytes. But here what is happening? Here they are solo, they are single, right? Why they are single? Because of there is a damage in the desmosome. Desmosome is the protein that is aggregating to keratinocytes. I think you are clear till now. Okay, first thing, where do we see acanthocytes? First thing is your pemphigus vulgaris. What is happening in pemphigus vulgaris? The antibodies are formed against which desmosomes, guys? Answer karo. Which desmosomes? Desmoglein 3, right? In pemphigus foliaceus, there will be antibody against desmoglein 1. Which desmosome? Desmoglein 1. Okay. In paraneoplastic or pemphigus, what will happen? There will be antibodies against desmoplakin or plakoglobin, right? In Darier's or Halle-Halle disease, there is antibody against calcium ATPase. Remember, calcium ATPase helps in the addition of the two keratinocytes, also helps in the addition of two keratinocytes. Okay, so this is very important table, guys. This is very important. First thing, in pemphigus vulgaris, there will be desmoglein 3. In pemphigus foliaceus, you can remember like F4 foliaceus, F4 first. Okay, so there will be desmoglein 1. Paraneoplastic pemphigus 2P, you can remember like desmoplakin and plakoglobin. And Darier's disease or Halle-Halle disease with the help of calcium ATPase, right? So these are your acantholytic cells. Okay, moving on to next is your microabscess. There are little microabscess, accumulation of neutrophils or lymphocytes or eosinophils in the cells, that is known as microabscess. Okay, so first thing, I will show you the image. You will be easily identifying all those images. Okay, I will tell you how to identify those images. First one is your papillary tip microabscess. Papillary tip microabscess, I have told you about the dermal papilla, right? Dermal papilla, there will be abscess, there will be accumulation of the substance. This is seen in which disease, guys? Papillary tip microabscess is seen in dermatitis herpetiformis. Dermatitis herpetiformis, right? Second thing is your Munro's microabscess. Munro's microabscess we will see in psoriasis. I will show you the image. Okay, in psoriasis, just remember the names now. Potrier's abscess we will see in cutaneous T-cell lymphoma, also known as mycosis fungoides. क्या बोलेंगे इसको? Mycosis fungoides. What do we call it? Mycosis fungoides. Mycosis fungoides is nothing but a cutaneous T-cell lymphoma, right? And the Kogoch pustules, these are also seen in the psoriasis. Okay, we will see for the images. These are also seen in the psoriasis, right? Till now we are done with the epidermis. Okay, in epidermis we have seen the different kind of cells and different kind of pathologies, right? Let's move on to basement membrane zone. अब किसके बारे में पढ़ेंगे? Basement membrane zone. Let's talk about basement membrane zone. Very nice. Love, heal and grow. Pilot Saini. Let's talk about the basement membrane zone. Remember, guys, in epidermis we are having desmosomes that are connecting two keratinocytes. Look here, guys. In epidermis we are having desmosomes that are connecting two keratinocytes. This is how two keratinocytes are connected with each other with the help of desmosomes. Now this keratinocytes will be connected with the basement membrane with the help of which protein? Answer me, guys. Which protein? कौन सा protein होगा? Here should be hemidesmosomes. Hemidesmosomes, right? Let's talk about the structure of hemidesmosomes. This is the desmosomes. Okay, let's talk about the structure of hemidesmosomes. In hemidesmosomes we are having plectin, we are having integrin, we are having bullous BPAG1 and BPAG2. Okay, BPAG1 and BPAG2. Very nice, guys. Okay, so hemidesmosomal proteins are your BPAG1, BPAG2, your plectin, your integrin. These are the hemidesmosomal proteins. Okay, if there is mutation of BPAG1 or BPAG2, there will be a disease that is known as bullous pemphigoid. Don't worry, guys, these terms are like maybe you don't understand, but till the end of this session you will be easily identifying these terms. Okay, what is the meaning of pemphigus, what is the meaning of pemphigoid, all those things will be clear to you, right? Just be with me till the end of the session. Okay, so due to mutation in BPAG1 or BPAG2, there will be a disease that is known as bullous pemphigoid. You can remember with the name as well, BP. So BP, bullous pemphigoid, antigene 1 or 2. Okay. Moving on to next is your dermis, right? In dermis, what will happen? In dermis is further divided into two layers. First one is your papillary dermis. First layer is your papillary dermis. And second layer is your reticular dermis. दूसरी लेयर को क्या बोलेंगे? What do we call it? Reticular dermis, right? Reticular dermis. First layer is your papillary dermis. Second layer is your reticular dermis. All right. What is the collagen that is present abundantly here? That is your collagen number 1. And hyaluronic acid is the most abundant. And most abundant cells are your fibroblasts. Dermatan sulfate is also present there, right? So that is your dermis, blood vessels and all those things. Look here, guys. This is your papillary dermis. This one is your reticular dermis. These are your blood vessels, glands, and all those things will be there, right? Next thing is your subcutaneous layer, also known as hypodermis. Okay, also known as hypodermis. This is also known as panniculus. Once there was a question asked, what is the meaning of panniculitis? Panniculitis. The meaning of panniculitis is nothing but the inflammation of the subcutaneous layer. Okay, that is the inflammation of subcutaneous layer. All right, that is your panniculitis. Okay, so this is the subcutaneous layer. Okay, all right, we are done with the basic part. Okay, let's see one by one. We have seen the 3 layers. First one is your epidermis, then we have seen the dermoepidermal junction, then we have seen the dermis, and then we have seen the subcutaneous. 4 types of cells that we have seen. Let's revise one by one fast. Okay, we have seen the 4 types of cell. First one is your keratinocyte, second one is your melanocyte, third one is your Langerhans cell, and the last one is your Merkel cell, right? We have seen the 4 types of cells. In epidermis, we have seen the mnemonic, come let's grab some burger, right? C for corneum, L for lucidium, G for granulosum, S for spinosum, and B for bacil, right? Are we clear till now? Let's move on to next topic, that is your skin lesions. Okay, now we are going to talk about the skin lesions. Okay, कौन से skin lesions होंगे, that we are going to look here. All right, first thing, there are 2 types of skin lesions we are having. First one is your primary lesions, second one is your secondary lesions. Guys, hota kya hai? What is the meaning of primary lesions? Primary lesions are those lesions which develop due to primary disease. Okay, जो disease की वजह से होगा, that is your primary lesions. What is secondary lesions? Secondary lesions क्या होते हैं? These are the lesions. These are basically primary lesions that are converted to secondary lesions due to inadequate treatment or due to trauma. There are multiple reasons, right? So basically this is the difference between primary and secondary lesions. Okay, देखते हैं what are the primary lesions that we should know. First one is your macules, papule, nodule, tumor, plaque, wheal, vesicle, bulla, pustule. Okay, secondary lesions are your scales, crust, fissure, ulcer, scar, and atrophy. Let's see one by one about all these lesions. Okay, so first one is your bulla. Bulla is nothing but your fluid-filled lesion. Bulla is your fluid-filled lesion. Whenever you will study bulla in dermatology, that means something is fluid-filled, which is more than size. These are depending on the size, which is more than 1 centimeter. Okay, if the fluid-filled lesion is there but the size is less than 1 centimeter, then we call it vesicle. Okay, so if the size is less, we call it vesicle. If the size is more, we call it bulla. Remember, here the fluid will be clear fluid. Fluid कैसा होगा? The fluid will be clear fluid. Okay. Second thing, let's talk about flat lesions. These are your fluid filled lesions. Let's talk about some flat lesions. First one is your macule. What is the meaning of macule? Macule is less than 1 centimeter. This is a flat discoloration that is less than 1 centimeter. Alright. If it is more than 1 centimeter, what do we call it? We call it patch. Okay. Patch is also a flat lesion that is more than 1 centimeter. If there is discoloration more than 1 centimeter, तो उसको क्या बोलेंगे? What do we call it? Patch. Okay. So 2 lesions till now we have seen. Third thing is your, let's talk about solid lesions. Okay. First one is your papule. Papule is less than 0.5 centimeter. Okay. If it is less than 0.5 centimeter, we call it papule. Okay. If it is more than 1 centimeter, what do we call it? Plaque. Okay. These are your solid lesions. Okay. These are your superficial solid lesions. All right. Now what will happen if these lesions are deep? If these lesions are deep, what do we call it? We call it nodule. If these lesions are deep and size will be more than 1 centimeter, we call it nodules. Okay. And if these nodules or these lesions will be having pus in them, we call it pustule. Agar pus hoga, if pus will be there, we call it pustules. Okay. If the size is more, then what do we call it? Abscess. Okay. If it is more than 1 centimeter and there is pus filled lesion, then we call it abscess. Okay. Clear till now? Okay. Let's talk about wheal. What is wheal? Wheal will be erythematous lesion. Wheal are characteristic feature of which disease? बताओ मुझे. Answer me. Wheal are characteristic feature of which disease? Okay. These are your primary lesions. Let's talk about secondary lesions. First one is your scale. Okay. Scaling क्या होता है? Scaling is basically the epidermal thickening. What is the meaning of scaling? Scaling is basically the epidermal thickening. Right. कौन सी layer का होगा? That will be which layer? Stratum corneum. Second thing will be crust. Crust is nothing but your dried up exudate. Crust क्या होता है? What is crust? Crust is nothing but your dried up exudate. Right. And the third thing is your fissure. Fissure क्या होगा? Fissure will be there is a simple crack in the skin. Right. Excoriation meaning of excoriation is a linear erosion. Remember guys, the meaning of erosion is in the epidermis. That is loss of epidermis. Loss of epidermis is known as erosion. And if along with the epidermis, dermis is also involved, then we call it ulcer. What is ulcer? Loss of epidermis along with dermis. Okay, that is known as ulcer, right? So that is linear erosion is known as excoriation, and erosion is simple, loss of epidermis, and ulcer will be loss of epidermis along with dermis. Lichenification, what will happen? There will be thickening of the epidermis and hypertrophy will be there. Okay, in scar also there will be hypertrophic changes. You can see easily, right? Scar is also a secondary lesion. Okay, so I think till now we are clear with the primary and secondary lesions. Okay, primary lesions are those lesions that develop primary in the disease. Secondary lesions are those lesions that develop after the disease, right? Secondary lesions, for example, let's say scar is like it is a secondary change, right? So are we clear till now? Let's move on to next thing is your skin appendages. Okay, next thing is your skin appendages. What are the skin appendages that we know? First thing is your hairs, second thing is your nails, and third thing is your glands. Okay, we are studying dermatology. In dermatology we have seen about the skin, and what are the skin appendages? Those are connected with the skin. So these will be hairs, these will be nails, and these will be glands. Okay, we will be doing it with the help of images only, right? So let's talk about glands first. We are having two types of glands in the skin. First one is your sweat gland, and second one is your sebaceous gland. Very nice. Okay, sweat glands and sebaceous glands. Sweat glands can be further divided into two types. They can be ecrine, they can be apocrine. Let's see one by one. Okay, let's talk about nails first. Okay, so these are the various nail pathology I've clubbed together in a single page. Okay, these are the various nail pathology. right? Can anyone tell me what is the protein that is present in nails? कौन सा protein होता है? Which protein is present in nails? Which is the protein? The protein that is present in nails is your keratin protein. Keratin. Okay, let's talk one by one. First thing, you can easily identify this image, that is your clubbing. Okay, clubbing is due to any kind of chronic illness. Clubbing कब दिखेगा? This is due to any kind of chronic illness. Most commonly hypoxic disorders like COPD. Most commonly it is seen with the hypoxic disorders like COPD, emphysema, and lung pathologies mainly, right? So that is your clubbing. Second thing is your koilonychia. What is the meaning of koilonychia? The meaning of koilonychia is spoon-shaped nail. Spoon-shaped nails, right? Are you able to see? These nails are looking like spoon, right? So this is your koilonychia. It is where do we see koilonychia? Patho से connect करेंगे. We can see in iron deficiency anemia along with Plummer-Vinson syndrome. Plummer-Vinson syndrome. Which syndrome? Plummer-Vinson syndrome. In Plummer-Vinson syndrome, what do we see? What is the triad of Plummer-Vinson syndrome? Anyone please try to answer. What is the triad of Plummer-Vinson syndrome? Right. Next thing is your Aldrich-Mees line. Third thing is your Aldrich-Mees lines. These are your horizontal lines. Horizontal lines. Where do we see Aldrich-Mees lines? We will see in arsenic poisoning. कौन सा poisoning में मिलेगा? There we will see it in arsenic poisoning. That is your proximal nail fold, which is steering the nails into two parts. That is known as pterygium, and it is a characteristic finding of which disease, guys? It is a characteristic finding of pterygium is a characteristic finding of lichen planus. Okay. Next thing, this was a previous year question, both of them. Okay. Next thing is your oil drop sign or thimble nails. What is the meaning of thimble nails? Thimble nails means pitted nails. Okay, there will be pitted. These are your pitted nails. Okay, thimble nails and pitted nails. These are the features of psoriasis. Okay, I will tell you the mnemonic. You can remember. I will tell you in psoriasis. Okay, so these are the features of psoriasis. Thimble nails are the most common feature of psoriasis. While oil drop sign, look here, this is oil drop sign. This is the most characteristic feature. This is the most characteristic feature of psoriasis, right? Moving on to next. Just a minute, guys. Alright, look here. Next thing is your Buse line and Muir-Case line. Buse lines are your growing and depressed lines. These are your growing and depressed lines. While Muir-Case lines are your these are your horizontal non-growing and non-depressed lines. Okay, both of them we will see in chronic illnesses. कहाँ मिलेगा? We will see in chronic illnesses. Both of them. Alright. Next one is your onychogryphosis. Onychogryphosis. Look here. This is the distorted nail we will see in the due to trauma. What is the cause? Due to trauma. Okay, this is due to trauma. What do we call it? Ram's horns nails. Okay, the another name for this is Ram's horns nail. Okay, this is due to trauma. Right. Next one is your half nail sign or Lindsay's nail. क्या बोलेंगे? Half nail sign and Lindsay's nail. Look here. White part along with the red part. Okay, there is some erythema. This part is white. That is the nail that we will see in which disease? Chronic renal failure. Same is that Terry's nail, but how do we differentiate? There will be ground glass opacities. Ground glass opacity in Terry's nail. Look here, guys. This is white, right? This will be your Lindsay's nail. This will be your Terry's nail. We will see Terry's nail in pemphigus and hepatic failure as well. Hepatic failure. Okay. So this is the nail pathology that we have seen till now. So the first appendages that we have seen, that is your nails. Are we clear with the nails? What is the meaning of clubbing, koilonychia, Aldrich-Mees lines and all those things, right? Let's move on to next. Next is your hairs. Okay, what is let's talk about hairs. What are the three basic stages of hairs? First one is your anagen phase, second one is your catagen phase, and the third one is your telogen phase. Anagen phase, remember guys, this is the growing phase. This is the growing phase. Okay, this one is the catagen is the transient phase. Catagen is the transient phase. Transient phase, and the telogen is the resting phase. Can anyone tell me the time periods? Time periods of these phases. Growing phase will be for the 2 to 6 years. Catagen will be for few weeks, right? For example, let's say 3 weeks. Okay, and resting phase, transient phase will be for the months. Okay, this will be for the months. Okay, what do we call the study of hair? Study of hair is known as trichology. What do we call study of hair? That is known as trichology. Okay, let's talk about alopecia. What is the meaning of alopecia? The meaning of alopecia is there will be loss of hairs. The meaning of alopecia is loss of hairs. Very important guys, alopecia. Okay, multiple things. First thing is your male pattern baldness. Male pattern baldness क्या होता है? Where do we see male pattern baldness? In males, the hairs will be losing from this part. First this part and this part. That pattern is known as, what do we call it? Which pattern is this? Hamilton pattern. This pattern is known as Hamilton pattern. Hamilton pattern, right? In male, the male pattern baldness, that pattern is known as Hamilton pattern. In female, what will happen? The hair loss will occur from this portion, that is vertex, or from the from where the girl part their hairs. Okay, so in females we are having two things. First one is your Olsen, and second one is your Ludwig. Two pattern of hair loss that will be seen in females, right? All right. Third thing is your alopecia areata. Areata. The meaning of areata is from the specific area, right? From the specific area there will be hair loss, right? It is an autoimmune condition. Alopecia areata is a autoimmune condition, right? कैसा होता है ये? How is this? Autoimmune condition. So, what will happen? Two things we should remember. Two most important questions that has been asked from alopecia areata. First thing, two signs. First thing, these hairs are easily pluckable. Whenever you try to pluck the hair of alopecia areata patient, what will happen? The hair will be easily pluckable. Okay, turning of gray phenomena also you see, right? So what will happen? Whenever you try to pick the hair, what will happen? The left stump will be there, and this left stump will give rise to a classical appearance that is known as which sign? Exclamation mark sign. Okay, that is known as exclamation mark sign. Okay, and second thing, around that space there will be abscess formation that is known as swarm of bee appearance. Neutrophilic abscess will be there, and that is known as swarm of bee appearance. These two things are most important, right? Okay, swarm of bee appearance. Okay, exclamation mark sign, very good, exclamation mark sign will be there, and swarm of bee appearance will be there, right? Very good. Okay, very good question. Okay, next thing is your telogen effluvium. Telogen effluvium, remember I told you it lasts for months. Okay, for example, let's say telogen effluvium patients comes to us with the history of let's say 3 months back patient has COVID, and now the patient is losing her hairs, right? So that is your telogen effluvium. That is your telogen effluvium. Next thing, scarring alopecia. Scarring alopecia, also known as cicatricial alopecia, we will see in let's say this is due to, we will see in discoid lupus erythematosus, that is due to radiation. Okay, these are some things that will lead to discoid lupus erythematosus, that will lead to scarring type of alopecia. Remember guys, SLE will show both scarring and non-scarring type of alopecia. Okay, that is important. Next thing is your trichotillomania. Trichotillomania is a psychiatric condition. It is a psychiatric condition in which what will happen? The patient will try to pluck out her own hairs. Okay, patient क्या करेगा? एक एक करके बाल खुद ही खींच लेगा. That is your trichotillomania. That is a psychiatric condition. Next thing is your traction alopecia. Traction alopecia is due to regular traction. बार बार खींचने की वजह से होगा. Okay, that is due to regular pulling of hair. Okay, Next thing is your anagen effluvium. Anagen is the growing phase. Remember, anagen is the growing phase. What will happen in anagen effluvium? That is due to chemotherapy. Okay, chemotherapy. Where do you see anagen effluvium? That is due to chemotherapy. I think we are clear till now. Yeah, right. Very good, very good. Heal and grow. All right, let's talk about some glands. Okay, we are done with the nails part. We are done with the hair follicle part. Let's talk about the glands. Okay, we are having sweat glands. I have told you we are having two types of sweat glands. First one is your eccrine, second one is your apocrine gland. First one is your eccrine gland, second one is your apocrine gland. Okay, eccrine, how do we remember? Eccrine gland, those are those glands that are present E for everywhere. Eccrine glands are present everywhere. First thing. Second thing, and they are under cholinergic control. C for cholinergic control. That means parasympathetic control. Cholinergic matlab parasympathetic control. All right. And what are the disorders? Let's talk about the disorders. The disorders, that is your prickly heat, or also known as malaria. This is red in color, so that is your malaria rubra. Rubra matlab, the meaning of rubra is red, so that is your malaria rubra, that is red in color. Okay, that is the inflammation of eccrine sweat gland, right? Let's talk about apocrine. The meaning of apo is together. Okay, so that is your together the hair follicle, or you can say along with the hair follicle. Next thing, A4, these are under the adrenergic control. These are under the adrenergic control. That means these are under the sympathetic control. कौन सा control होगा? There will be sympathetic control. Which is the disease that we need to remember? That is your phosphodiosis disease. What will happen? There will be inflammation of the apocrine sweat gland in the axilla part. Okay, and that will lead to a disease known as phosphodiosis disease. This is very important. Please guys, don't confuse phosphodiosis disease with the phosphodiosis disease with the phodiosis spores. Okay, let's talk about phodiosis spores. These are your sebaceous glands. Remember guys, sweat glands will be producing sweats. Okay, I have told you they are present in two places. Either they can be opening with the hair follicle, either they are present in the every part of the body. Okay, in trunk mainly you have malaria, right? Malaria, that is your nothing but your ghamoria, you know, ghamoria, right? Okay, next thing is your sebaceous gland. The function of sebaceous gland is to produce sebum, right? They will produce sebum, right? And when they open with hair follicle, we call it a pilosebaceous unit. We call it pilosebaceous unit. We call it pilosebaceous unit. Look here guys, what will happen in pilosebaceous unit? This is the pilosebaceous unit. If there is inflammation of a pilosebaceous unit, what will happen? It will lead to acne formation. What is the acne formation? That is nothing but the inflammation of the pilosebaceous unit, right? And if these sebaceous glands, they are present ectopic. Ectopic matlab जहाँ होना चाहिए वहाँ नहीं है, they are on the different side. Okay, they are on the different side. Then it lead to a disease known as phodiosis spores. That means the sebaceous glands which are present on your lips, these are your ectopic sebaceous glands. That is known as phodiosis spores. Remember guys, phodiosis spores are ectopic sebaceous gland, whereas phosphodiosis disease is which gland? Apocrine gland. Okay, apocrine gland. Okay, let's talk about acne one by one. What are the different kind of acne? First thing is your mild acne, second one is your mild to moderate, third one moderate to severe, and last one is your severe acne. Okay, comedone are the basic lesions. First one, black comedones, these are your open acne, and second one is your white comedones, these are your closed acne. We can also call it blackheads or whiteheads. Blackheads कैसे होते हैं? They are open. Okay, and whiteheads are closed. They are in mild to moderate. What we need to do? We need to treat them. How do we treat them? That is very important, right? In mild to moderate, we need to give a drug that is known as कौन सी दवाई देते हैं वो, विच इज़ द ड्रग दैट वी गिव फॉर एक्ने, विच इज़ द ड्रग, आंसर. Till then I will be telling you about the moderate severe. Please try to answer. Which is the drug that we give for mild to moderate acne? Very nice. Love, heal and grow. Very nice. Very nice, pilot. Okay, so the drug that we are giving is your nothing but your retinoids. Retinoids, guys, retinoids. Okay, retinoids like adapalene, tretinoin. Okay, so for mild to moderate we are giving topical retinoids. Topical retinoids. Okay, in moderate condition, what do we do? In moderate condition, along with the topical retinoid, what I will add? I will add antibiotics. Okay, topical antibiotics like clindamycin. Remember clindamycin. Till then, please try to answer which is the most common organism, like from microbiology, which is the most common organisms causing acne. Which is the most common causative organism that is causing acne, right? Here we are giving topical retinoids along with the topical antibiotics. In moderate to less severe, what we do? We will give topical retinoids along with antibiotics along with benzyl peroxide. Okay, benzyl peroxide we can add, and in the severe form, what we need to do? We need to give isotretinoin. That is most important. Isotretinoin. It has a side effect that you already know. Side effect in pregnancy. Okay, pregnancy mein that is a teratogenic drug. Okay, so we need to be cautious while giving the isotretinoin to the patient, right? So these are the basic treatment of acne and basic types and grades of acne. Okay, the organism that is responsible for causing acne, that is most common, is Propionibacterium. Propionibacterium, that is also very important, that is causing acne. Propionibacterium. Okay, till now we are done with the appendages as well. Skin appendages are also clear. Let's talk about some papillosquamous disorders. In papillosquamous disorders, we are going to study about the psoriasis, lichen planus and all those things. Okay, so psoriasis is very important. Already there are multiple questions in every exam that has been asked from the psoriasis. Okay, so let's talk about one by one. First thing is your psoriasis. Psoriasis is a autoimmune disorder. Autoimmune disorder hai. What is the most common site where psoriasis will occur? That is your which surface? Extensor surface. Remember guys, psoriasis will occur on the extensor surface. Okay, most common type of psoriasis is psoriasis vulgaris. Okay, psoriasis vulgaris. Remember guys, the meaning of vulgaris in derma will be most common. Wherever you will see vulgaris, that means most common. Most common type of TB, that is lupus vulgaris. Most common type of ichthyosis, that is ichthyosis vulgaris. Most common type of psoriasis, that is psoriasis vulgaris, right? That is very important, right? Let's see one by one. With the help, let's remember with the help of a mnemonic, that is polish. Okay, P for there will be pitting. Okay, we have seen already in the nail changes that there will be pitting. O is oil drop sign, that you already know, oil drop sign. O and L is onycholysis. Onycholysis, that is destruction of nails. Onycho मतलब क्या होता है? That is the meaning of nails, right? So onycholysis means there will be destruction of the nails, right? I for irregular. So the pitting will be irregular. Pitting will be irregular here. Okay, and S and H for subungual hyperkeratosis. Hyperkeratosis, that is excessive keratinization below the nails, right? So that is, these are the specific feature. With the help of a mnemonic we have remember which type of pitting we will see here. Irregular pitting. Okay, deep regular pitting is a feature of. Answer in the comment section. Deep regular pitting is a feature of? In which disease? We have already covered. Answer. Okay. Deep regular pitting is seen in which disease, right? Look here, guys. So this is the pitting. Irregular pitting you have seen. Second thing, that is your oil drop sign. This is your oil drop sign. Okay. Third thing, that is your distortion of the nails. That is your onycholysis. These are the feature of psoriasis. This is your onycholysis, right? And this one is the silver scaling. Okay, this is the silver scaling. Remember, guys, wherever you will see silver scaling, you will be looking for psoriasis. Okay, when you will try to remove that membrane, there is a membrane that is known as Berkeley's membrane and Warnoff ring. Okay, whenever you will try to remove that skin, whenever you will try to remove that ring, what will happen? There will be pinpoint bleeding. Okay, pinpoint bleeding on removal of Berkeley's membrane, that is known as Auspitz sign. Okay, that is known as Auspitz sign. क्या बोलेंगे इसको? What do we call it? Auspitz sign, right? So this is very important. Very good, Lavil. All right, deep regular pitting is seen in alopecia areata. All right, let's talk about the histopathology. Okay, histopathology. First thing, we will try to orient ourselves to the normal structure. What we have seen, this is your stratum. These are the epidermal layers. Okay, these are your epidermal layers. What do we see here? There will be hyperkeratosis. Hyperkeratosis means there will be abnormal keratinization, more keratinization. Okay, there will be more keratinization. First thing clear. Second thing, this is your rete. Okay, this is your rete. We have seen that epidermis is going into the dermis, that is known as rete ridges. Okay, so there will be club shaped rete ridges. Okay, third thing we have seen in parakeratosis, we will see parakeratosis. What is the meaning of parakeratosis? You know, the meaning of parakeratosis is retained nucleus in the stratum corneum. Okay, there should not be any blue dot. Here, but look, here is a blue dot. Okay, that means the in the stratum corneum, this is the stratum corneum. Okay, and there is a blue dot, that means there is a nucleus in the stratum corneum. And if there is a nucleus in the stratum corneum, what do we call it? We call it parakeratosis. What do we call it? Parakeratosis. Remember the mnemonic that we have studied? Peace, right? Peace. Okay, next thing is your spongiform pustule of Cogos and Spinosum. Okay, these are your pustule, Cogos pustule. Okay, these are nothing but your neutrophilic infiltration. Okay, look here, neutrophilic infiltration is the stratum spinosum. Okay, spinous layer, that is your Cogos pustule. We have seen in the microabscess, Cogos pustules are seen in psoriasis, right? And this one is the Munro's microabscess. These are also neutrophilic infiltrate. In the stratum corneum. This is also a feature of psoriasis. Okay, this is also a feature of psoriasis. And dilated blood vessels are also there. So remember, guys, these are very important: hyperkeratosis, parakeratosis, Munro microabscess, and Cogos pustule and club shaped rete ridges. These are the characteristic feature of psoriasis. अगर psoriasis की histopath की image आएगी, I hope you guys can easily identify. Okay, so these are the features that you should look for. Okay, so this is your psoriasis. Okay, if in that psoriasis there is a pus filled lesions, okay, then we call it pustular psoriasis. अगर वहाँ पर क्या है scaly silvery scaly lesion के साथ में there will be pus, then we call it pustular psoriasis. Okay, pustular psoriasis. And if it is generalized all over the body, then we call it von Zumbesch disease. What do we call it? Von Zumbesch disease. This is a scalp psoriasis. Look here, guys, silvery scale. You can see silvery scales, right? This is your scalp psoriasis. Okay, generally I have told you psoriasis is present on extensor surface. कौन सी surface पे होगा? Psoriasis will be in the extensor surface. But if psoriasis is in the flexor surface, okay, look here, psoriasis is in the flexor surface, so we call it inverse psoriasis. Okay, and if there is psoriasis in the pregnancy, then we call it impetigo herpetiformis. What do we call it? Impetigo herpetiformis. Impetigo herpetiformis का मतलब क्या होता है? The meaning is psoriasis in the pregnancy. Okay, erythrodermic psoriasis you will be easily identifying, because look here, erythrodermic means red. Okay, there will be redness, so it is redness is there, that is your erythrodermic psoriasis. Gutted psoriasis, you will see structures like all those guttes. Okay, so this is your gutted psoriasis. Gutted psoriasis generally after the upper respiratory tract infections in children, right? So that is your gutted psoriasis. Okay, how do you treat? Can anyone tell me what is the drug of choice for pustular psoriasis? What is the drug of choice for pustular psoriasis? Remember guys, the drug of choice for pustular psoriasis is, pustular psoriasis के लिए drug of choice क्या होगा? Answer me. It is acitretin. The drug of choice for pustular psoriasis is acitretin, right? Second thing, for inverse psoriasis we give methotrexate. In impetigo herpetiformis, में क्या होगा? The patient will be in the pregnant state, right? So patient will be pregnant, so what we can give? I can use steroids. Okay, I can use steroids here, or I can use cyclosporine as well. Okay, cyclosporine as well. In erythrodermic psoriasis also I give methotrexate. Okay, methotrexate, I can give methotrexate. In gutted psoriasis, remember gutted psoriasis is after the upper respiratory tract infection. So I will try to resolve the primary cause, and for that purpose I will be giving antibiotics, right? I will be giving antibiotics, right? Are we done with the psoriasis? इसमें से क्वेश्चन गलत नहीं करना. These are the most important topics. Psoriasis and lichen planus. Always question is from there. Okay, every year there is a question, so please try to remember one by one everything. Okay, moving on to next is your lichen planus. दूसरा क्या है अगला? What is next is your lichen planus. In lichen planus you need to remember 5 P's. Okay, 5 or 6 P's you can say if you include pterygium. Okay, so 5 P's are your, they should be plain, polygonal, pruritic, papule, plain, polygonal, purple, pruritic, papule. Okay, so these are the 5 P's, and 6th P will be pterygium. Okay, pterygium is very important. Pterygium is when proximal nail fold is coming and tearing apart the nail into 2 parts. ये क्या हो रहा है? This is tearing apart the nail into 2 parts. That is your lichen planus. Okay, you can see these lesions are plain topped. Look here for the lesions, guys. These lesions are purple and these are plain topped. Okay, they are plain topped. Okay, these are violaceous lesions. One more thing, that is your Wickham stria. They will involve the mucosal involvement. That is your mucosal involvement. Reticular lacy pattern will be there, that is your Wickham stria. Okay, pterygium is very important. Now look for the histopathology of lichen planus. What you will see, first thing, that is your hyperkeratosis means there will be increased keratinization. Okay, second thing will be hypergranulosis. Look here guys, this is the granular layer, there will be hypergranulosis, the increased amount of granules, right? Third thing will be, look for the rete ridges, guys. Rete ridges here, these are your rete ridges. Look here guys, these rete ridges are looking like a sawtooth. Okay, these rete ridges are looking like a sawtooth, right? So these are known as sawtooth rete ridges. This is a feature of lichen planus. Okay, this is a feature of lichen planus. Remember guys, in psoriasis we have seen elongated rete ridges, badi rete ridges, right? We have seen the elongated rete ridges or clubbed shaped rete ridges. Here the rete ridges will be sawtooth like, so you can easily identify. Third thing will be, there will be infiltrate, that is known as lichenoid infiltrate. Okay, second most important thing, that is your the Max Joseph cleft, that is a space between these two structures. There will be a space that is known as Max Joseph cleft. And which bodies are there? Cavate bodies are also called as colloid bodies. Colloid bodies are also present there. Okay, cavate bodies or colloid bodies. So these are the specific features that would be helpful for you guys to identify lichen planus as well as psoriasis, right? All right. One more thing that you need to remember, that is your isomorphic phenomena, also known as Koebner's phenomena. Koebner's phenomenon. What is the meaning of Koebner's phenomena or isomorphic phenomena? For example, let's say if I am having psoriasis, if I am having lichen planus, I will try to scratch here, or is there any trauma here? What will happen? There will be appearance of this type of scars. Okay, this type of lesions will be appeared, right? That is known as Koebner's phenomena. Koebner's phenomena, true Koebner's will be seen in lichen planus, psoriasis, and vitiligo, right? In lichen planus, psoriasis, and vitiligo. False Koebner's will be seen in warts and molluscum contagiosum. Okay, these are due to autoinoculation, basically. Autoinoculation. That means the organism is coming from one place and it will be going to the another place because of touching, right? So that is your false Koebner's phenomena is seen in warts and molluscum contagiosum, and true Koebner's is seen in lichen planus, psoriasis, and vitiligo. This is a 2 times asked question in NEET PG as well as FMG examinations, right? So moving on to next is your lichen nitidus. Lichen nitidus, also known as mini lichen. क्या बोलेंगे इसको? What do we call it? Mini lichen, right? Okay, that is your mini lichen. What will happen? In your extensor surface around your elbow, there will be small dots. Okay, that is known as mini lichen. Okay, there is a very characteristic appearance that is known as ball in claw appearance. Ball in claw appearance. Ball in claw appearance is a specific feature of lichen nitidus. It is a specific feature of lichen nitidus. कहाँ मिलेगा ball in claw appearance? You will see in lichen nitidus. Okay. Next one, moving on to next is your Pityriasis rosea. क्या बोलेंगे इसको? Pityriasis rosea. Pityriasis का मतलब क्या होता है? The meaning of pityriasis is scaling. Okay, wherever you will see the word pityriasis, that is scaling. Okay, so first patch that you will see, that is known as mother patch, also known as herald patch. क्या बोलेंगे इसको? What do we call it? Herald patch or mother patch. Then what will happen? Appearance of first patch will occur first. Then what will happen? There will be growth. Okay, and that growth will be in a specific pattern that is known as fir tree pattern or Christmas tree pattern, right? Okay, fir tree pattern or Christmas tree pattern. The most important thing is what kind of scales do you see? Okay, what kind of scales do you see? You will see collarate of scales. That is also known as cigarette paper scale. Cigarette paper or collarate of scale is a feature of Pityriasis rosea, right? Next thing, silver white scale. Where do you see silver white scales? Silver white scales are seen in psoriasis. Remember, we have seen silver white scales. We have seen in psoriasis. Fish-like scaling is seen in ichthyosis vulgaris. Okay, greasy scales will be seen in guys. Greasy scales will be seen in seborrheic dermatitis. There will be greasy scales. Okay, and the last thing will be brainy scale or rice grain scale. Please try to answer in the comment section. Brainy scale or rice grain scales are seen in. Very good. Love Hill Grow. Very good. It is seen in Pityriasis versicolor. So the meaning of pityriasis is scaling, right? Are we clear till now? Okay. So with this, we are done with the papillosquamous disorders, right? These are the 3 most important things, 3 to 4, that should be remembered by you for the examination. Okay. If you remember these things, you can easily identify whether it is psoriasis, whether it is lichen planus, and you will be good to go. Okay, next thing is your infections. Okay, let's talk about some infections. First one is your bacterial infection. We are having bacterial infection, fungal, viral, and parasitic infections. Okay, so the first thing is your bacterial infections. In bacterial infection, look at this. What do you see? What is the causative organism of erythrasma? Can anyone tell me? The causative organism of erythrasma, this is very important, again and again asked multiple times. That is your Corynebacterium minutissimum. Minutissimum. Corynebacterium minutissimum. Okay, that Corynebacterium minutissimum will release a keratolytic enzyme. Okay, that will release a keratolytic enzyme. Keratolytic enzyme that will lead to damage of the keratin cells. Okay, if it is present in your axilla, how you will identify with the other, how you will differentiate? You will look for this with the help of wood lamp examination. Wood lamp examination. You will do a wood lamp examination, and in wood lamp examination, what kind of appearance do you see? That is the expected question. That is your, what kind of appearance do you see? That is your coral red appearance. That is your coral red appearance. What kind of appearance you will see? Coral red appearance. दिख रहा है? This one is your coral red appearance on erythrasma, right? Next one is your ichthyma. Okay, ichthyma is multiple types. I have grabbed it all together here. First one is your ichthyma pyogenicum. Ichthyma pyogenicum is due to Streptococcus pyogenes. Okay, किसकी वजह से होगा? What is the causative organism? That is your Streptococcus pyogenes. Second one is your ichthyma gangrenosum. Gangrenosum किसकी वजह से होगा? That is due to Pseudomonas. किसकी वजह से होगा? That is due to Pseudomonas. And the third thing will be ichthyma contagiosum. These are very contagious nodules. Okay, so that is due to parapox virus. किसकी वजह से होगा? Which virus will be there? That is your parapox virus. Okay, so third thing, we have three things we have seen: ichthyma pyogenicum, ichthyma gangrenosum, ichthyma contagiosum. Okay, pyogenicum will be P for pyogens. Gangrenosum will be Pseudomonas, and the third thing will be contagiosum. Contagious are your viruses. Viruses are your contagious things. Okay, so that is your ichthyma contagiosum. Okay, next thing is your impetigo. Okay, let's talk about impetigo. Impetigo is of two types. First one is your non-bullous type. Second one is your bullous type impetigo. Okay, look here. What you will see? Honey colored crusting. Okay, crusting. Now you can easily identify that crusting is a secondary lesion, right? Honey colored crusting, that is nothing but your dried up exudates, right? Honey colored crusting is seen. So that is due to which organism? Staph or strepto? That is due to strepto followed by staph. Okay, Streptococcus is the causative organism for non-bullous impetigo. For bullous impetigo, there will be Staph aureus, right? All right. So that is all about the impetigo. Okay. Now let's talk about the cellulitis versus erysipelas. Okay. Both of these are look like similar things, but these are not similar. Okay. This is very important to understand that erysipelas will be superficial. Okay. This will be superficial, while the cellulitis will be deep. Cellulitis will be extending up to the subcutaneous, okay, till the fat cell layers. Okay, so that will be deep, and this one will be superficial, right? Second thing will be demarcations. So there will be clear cut margin. Okay, clear cut margin, or they are sharp. This will be diffuse. Okay, what are the causative organism for cellulitis? The most common is staph aureus. The most common organism will be staph aureus. In erysipelas, the most common organism will be group A beta hemolytic streptococci, right? So these are the difference between cellulitis and erysipelas that you should remember, right? Okay, till now we are done with the bacterial infection. Let's move on to some fungal infections. Okay, fungal infection dekhte hain. First one is your pityriasis. You know pityriasis, the meaning will be scaling. Okay, now tell me, in pityriasis versicolor what kind of scales do you see? कौन से scales है? Scales in pityriasis versicolor, what kind of scales do you see? Answer me, right? Okay, what is the causative agent for pityriasis versicolor? What is the causative agent? This is your Malassezia globosa. Malassezia globosa followed by Malassezia furfur. Okay, Malassezia globosa followed by Malassezia furfur. Next thing, what is the most common site? Most common site will be trunk. What you will see? You will see hypo and hyperpigmented patches on your trunk, right? That is your pityriasis versicolor. When you try to see these lesions under the wood lamp examination, what you will see? You will see apple green color in wood lamp examination. Okay, in wood lamp examination you will see apple green color. On microscopy, what you will see? You will see this appearance that is known as spaghetti and meatball appearance. On microscopy you will put KOH mount, then you will see spaghetti and meatball appearance, also known as banana and grapes appearance. Okay, that is your banana and grapes appearance. Okay, what kind of scales you see? Fine rice and brainy scales. Very nice. Okay, fine rice scale, or we can also call it as brainy scales. What do we call it? Brainy scales or fine rice scales. Okay, very important. Spaghetti and meatball. Very nice, right? Okay, so next thing will be, how do you treat it? The treatment will be selenium sulfide, or you can use any kind of azoles. Okay, like ketoconazole, fluconazole and azoles. Okay, next thing is your pedra. Okay, we are having two types of pedra. First one is your black pedra, second one is your white pedra. This one is white pedra and this one is your black pedra. Okay, this one is your black pedra. Black pedra is due to which organism? Pedra horte. Remember, whenever we will wear black, we look hot, right? We can remember like that. I remember like that. Black will be horte. Second thing is your white pedra. White will be trichosporon bijili. You can remember like bijili. Bijili is like light. Bijili in Hindi, bijili is light. Okay, so that will be white in color. Okay, so trichosporon bijili will be for the white pedra, and for the black pedra the organism will be pedra horte. Remember this, very important guys. Okay, next thing will be dermatophytes. What are the dermatophytes? क्या होते हैं dermatophytes? These are the organisms. What are dermatophytes? These are the organisms. First one is your trichophyton, second one is your epidermophyton, and third one is your microsporon. Look here guys, first one is your trichophyton. All three things will be there. Okay, what are the all three appendages that we have seen? First one is your skin, second one is your nails, and third one is your hairs. So they will affect all three things. Okay, epidermophyton, remember after E there will be H, so it will not affect H. Microsporon, after M there will be N, so it will not affect N. Okay, so epidermophyton will be affecting epidermis, or you can say skin, or you can say nails. Another way to remember, you can remember like that. In epidermophyton there is epidermis, so it will be affecting epidermis. Second thing, in the end it is N, so it will be affecting the nails. Okay, microsporon, it won't affect nails, right? So it will be affecting skin and hairs. Okay, it will be affecting skin and hairs, right? So now let's talk about tinea. Okay, tinea infection. Let's talk about tinea. So these are your head swellings. Okay, first one, very important guys, these are repeatedly asked questions. Please try to concentrate. First one is your, the question will give tender boggy swelling. Question will give tender boggy swelling. It is a feature of Kerion. Remember guys, this is a painful tender boggy swelling that we will see in the Kerion. Okay, that we will see in the Kerion. What is the causative organism for Kerion? Please try to answer. What is the causative organism for Kerion? Okay, second thing is your scutula, or you can call it Phoebus. Scutula or Phoebus. The causative organism will be Tinea stoloni. Okay, that is the causative organism for Phoebus. Okay, look here, this is your crusting. There will be crusting. Here will be painful boggy swelling. There will be pus. Okay, that will be painful. This is your black dot. This is your black dot, and this one is your gray patch. Gray patch. So basically these are your tinea infections. Okay, for Kerion, the organisms will be answer guys, tinea mentagrophyte or verrucosum. Tinea mentagrophyte or verrucosum. Okay, so that is the organism. How do you treat tinea capitis? Look here guys, for treatment of tinea capitis we will give griseofulvin. 10 to 20 mg body weight के हिसाब से देंगे. That is your griseofulvin, right? Next tinea is your tinea cruris, also known as dhobi itch. Okay, that is your dhobi itch. This one is your tinea corporis, and this one is your tinea unguum, or we can say tinea pedis. Tinea pedis is also known as athlete's foot. Because they wear shoes for longer period of time, there will be tinea infection, there will be fungal infection, that is athlete's foot. Okay, for treatment of this we will give, the drug of choice will be terbinafine followed by itraconazole. Itraconazole, right? In tinea there will be central clearing. What will happen in tinea? There will be central clearing. Okay, there will be clearance in the center. Okay, there will be central clearing. Central scarring will be seen in lupus vulgaris. I have told you the meaning of vulgaris will be most common. Lupus vulgaris is the most common form of TB. Next one is your central crusting. Will be seen in leishmania. Okay, central crusting कहाँ मिलेगा? It will be seen in leishmania. Okay, next one is your sporothrix. Okay, sporothrix, the causative agent will be sporothrix shanki. Okay, that is your causative agent. Remember guys, the root is lymphocutaneous. Okay, lymphocutaneous root. This is also known as Rose Gardner's disease, Valentine disease, and this is due to prick. Of thorn. Okay, क्यों होगा? That is due to prick of thorn. What will be the drug of choice here? The drug of choice will be itraconazole. Remember guys, the drug of choice will be itraconazole. Okay, what do you see? This on histopathology, these bodies are known as asteroid bodies. Okay, these are known as asteroid bodies. Asteroid bodies are feature of sporotrichosis, and this lymphocutaneous spread is also seen in sporotrichosis. Are we clear till now? Okay, moving on to next is your identify the disease guys. What are these bodies known as? What are these bodies known as? Try to answer guys. These bodies are known as, very nice. These bodies are known as this disease is known as chromoblastomycosis, and these bodies are known as copper penny bodies. Okay, copper penny bodies, also known as, और क्या बोलेंगे, copper penny bodies or We can also call this medullary bodies, medullary bodies, also known as sclerotic bodies, okay, copper penny bodies, medullary bodies, sclerotic bodies, okay, muruliform bodies, multiple names. Okay, so these are the name for chromoblastomycosis. This is a colorful fungi. Okay, there will be warty lesions on the skin. Okay, that is the thing. How do you treat chromoblastomycosis? Remember, guys, for treatment of chromoblastomycosis, you will also use itraconazole. Itraconazole. Okay. Let's talk about parasitic infections, guys. I think we should take a break for like 10 to 15 minutes. Till then, you can revise or you can see once. I will send the PDF. Okay. Then only 20 slides are left. Then we will be completing in 1 hour. Okay. So just take a break for 10 to 15 minutes, and I will be back. Okay. I will be back at 7:50 sharp. Hello guys, welcome back to the session. Okay. All right. Welcome. Okay. Till now we have seen about the infections. In infections we have seen about the bacterial infections and viral infections, right? Now let's talk about some parasitic infections. Okay. So first one is your parasitic infection. Can anyone tell me what is the most what is the name of that disease? Okay. By looking at these pictures, just tell me the name of the disease. The name of the disease is, obviously I'm talking about scabies, right? That is caused by Sarcoptes scabi. That is the organism, guys. Look here, guys. This is the organism. Just remember the picture. This is very important. Okay. What is the most common site? If I ask you, what is the most common site? The most common site where this organism affect is known as circle of Hebra. Okay. That is known as circle of Hebra. Okay. And what is the most characteristic lesion? What is the most characteristic lesion? कौन सा होगा? What is the most characteristic lesion? Most characteristic lesion that you will see is burrows. Burrows दिखेंगे कहाँ पर? Most common area is your intertriginous space. Okay, burrows. Burrows are in which layer? Which layer of epidermis? We have seen 5 layers of epidermis. So burrows are in the layer of stratum corneum. कौन सी layer में होता है? Stratum corneum. That is your burrows, right? This disease is also known as, क्या नाम होगा इस disease का? Also known as Prince itch disease. Prince itch disease. Okay, this disease is also known as Prince itch disease, also known as 7 years disease. Okay, 7 years disease, 7-year itch disease, because there is a extreme pruritus. Okay, there will be extreme pruritus. This one is the Norwegian scabies. This is the worst prognosis of the scabies. This will be the worst prognosis, guys. Okay, if I talk about the treatment of the scabies, what will be the drug of choice? The treatment part, the drug of choice will be 5% permethrin. The drug of choice will be, guys, 5% permethrin, right? But in Norwegian scabies, we give another drug, that is your ivermectin. That is your ivermectin. क्या बोलेंगे इसको? Ivermectin. In Norwegian species, there will be a drug that is ivermectin, right? Are we clear? Yeah. All right. Next thing is your pediculosis. Pediculosis. This is a louse. Okay. Pediculosis. Let's talk about pediculosis. If it is in the head, we call it head louse. If it is in the body, we call it pediculosis corporus. But if it is in the pubis, we call it crab louse. Crab louse. That is important. In head, we call it capitis. In body, we call it corporus. But in the pubis, we call it crab louse. Okay. And what is the most characteristic lesion that you will see in pediculosis pubis? That is known as macula caerulea. That is known as macula caerulea, right? This is your louse. How you will treat louse infection? With the help of drug, same drug, that is your 1% permethrin. We can use 1% permethrin for louse as well. Okay, so these are your parasitic infections that you should remember. Question has been asked from these questions in the previous year examinations. All right, let's talk about some viral infection, viral etiology. First one is your molluscum contagiosum. Molluscum contagiosum. Okay, what is this lesion? What do we call it? क्या बोलते हैं इसको? What is this lesion is known as? Answer me. This is pearly white umbilicated papule. This is pearly white umbilicated papule. Characteristic feature of molluscum contagiosum. Okay, and this is known as Henderson Peterson bodies. Henderson-Peterson bodies. These are Henderson-Peterson bodies. These are also characteristic feature of molluscum contagiosum. Generally, where do you see molluscum contagiosum? These will be in the children's, like those who are having low immunity. Where there you will see molluscum contagiosum. How you will treat? You can use trichloroacetic acid. You can use cryotherapy. Okay, these lesions will show false cobnerization. Okay, I have told you false Cobner's phenomena, isomorphic phenomena, false cobnerization. Okay, cobnerization. That is also a feature of molluscum contagiosum. Podophyllin toxin we can also use, right? Next one is your human papilloma virus. Okay, HPV. This is very important and you should remember this. We can remember this with the help of a mnemonic, that is your DSP, come eat a burger. You can remember DSP, come eat a burger. This is very important. D for deep warts. Okay, S for superficial warts, P for plain warts, C for common warts, E for epidermolysis, epidermodysplasia verruciformis, A for anogenital wall, also known as also laryngeal warts. Okay, and the last one B for butcher's wart. Okay, DSP, come eat a burger, right? DSP, come eat a burger, you can remember with the help of this mnemonic. D for first. Okay, D is 1, so molluscum HPV type 1. S for type 2, P for planar, that is type 3 or 10, that is the previous year question. Okay, next one is your common warts, that is subtype 4, and for epidermodysplasia verruciformis, that is your 5 or 8. Okay, and 6 and 11 you already know, these are your anogenital warts. Okay, and laryngeal warts and butcher's wart. Okay, so this is the thing you should remember. Okay, you can remember with the help of this mnemonic, right? Next one is your bacterial infection, that is your mycobacterial infection. Look here guys, I have told you there is central, you can see central scarring. Central scarring is a feature of, I have told you, central clearing is a feature of, we have seen tinea infection. In tinea infection there will be central clearing. The center part will be cleared. Here what you will see, here you will see central scarring. Central scarring is a feature of lupus vulgaris. Lupus vulgaris is the most common TB, most common type of skin TB. Okay, most common type of skin TB. Okay, how you will identify? You will do a dioscopy, and when you will put this thing, you will find apple jelly nodules. कैसे nodules मिलेंगे? You will find apple jelly nodules. This is a characteristic feature. Okay, next thing is your scrofloderma. This is again most common TB, but in children. Most common TB in children is scrofloderma, right? So this is about the mycobacterial infection, TB, right? Let's talk about leprosy. Leprosy is due to Mycobacterium leprae. Okay, leprosy का causative organism क्या है? That is Mycobacterium leprae. From micro, can you tell me lepra, does it follow Koch postulate or does it not follow Koch postulate? And what is Koch postulate? Please try to answer. Okay, so Mycobacterium lepra, it is of two types. First one is your paucibacillary, second one is your multibacillary. If the lesions are 1 to 5, we call it paucibacillary, and if the lesions are more than 5, we call it multibacillary. This is a WHO classification on the basis of number of lesions. Okay, second thing, we will look for the involvement of nerves, right? Involvement of nerves, first thing will be if it is 0 or 1, or if it is more than 1 or more than 2, right? So that is your multibacillary. How we will treat? We will treat with the multi-drug therapy. The drugs will be same, but for paucibacillary the treatment will be 6 months. Okay, the treatment duration will be different, and for multibacillary the duration will be 12 months, right? This duration will be 12 months. What are the drugs that we are using? First drug will be rifampicin, second one will be clofazimine, and third one will be dapsone. Okay, rifampicin you have to take once a month, that you will go to, after 28 days you will go to clinic, you will get a 600 mg dose of rifampicin. Then they will give you a packet that will be comprising clofazimine for daily purpose and dapsone, D for dapsone, D for daily purpose. How much dapsone? 100 mg per day, and clofazimine 50 mg per day, and when you go to clinic you will be given 300 milligram of clofazimine, right? So this is the treatment part. Let's talk about lepra reactions. In leprosy there are two types of reaction. First one is your type 1 reaction, second one is your type 2 reaction. Can anyone tell me what is the type 1? Okay, in type 1 reaction, which type of hypersensitivity will be there? Which type of hypersensitivity will be there in type 1 reaction, and which type of hypersensitivity will be there in type 2 reactions? Can anyone tell me? You just need to make it 5, right? So type 1 reaction will be type 4 hypersensitivity, and type 2 reaction will be type 3 hypersensitivity. Okay, this is you should remember. Okay, next thing is your treatment. Okay, if these are lepra reactions are basically after let's say if some patient has you have prescribed some patient MDT, then the patient is going home, then after taking the treatment the lepra reaction will occur, right? So what you need to do, you need to stop the drug or you should continue? Definitely you should continue, right? So you should continue the drug along with some other drugs. Okay, so in type 1 lepra reactions, what is the drug that I will give? These are your steroids. Okay, so in type 1 lepra reaction the drug of choice will be steroids. Okay, second thing, in type 2 lepra reaction the drug of choice will be again steroids, but we can use another drug that is gold standard, and that is thalidomide. This is a question that has been repeatedly asked twice in the previous examination. Thalidomide. Can anyone tell me what is the specific side effect of thalidomide? It causes phacomelia. Cilium, right? It causes phacomelia. Okay, what is the classification that we use? That is known as Ridley-Joplin classification. कौन सा classification बोलेंगे? We call it Ridley-Joplin classification. In Ridley-Joplin classification, we have divided the leprosy into tuberculoid, borderline tuberculoid, borderline, borderline lepromatous, and ultimately the last one is your lepromatous leprosy. Okay, इनमें से क्या याद रखना है? The most important thing, क्या है? BT type of leprosy. BT type of leprosy is the most common in India, and some specific lesions you need to remember. Okay, क्या क्या lesion याद रखना है? BT type of leprosy is the most common in India, and satellite lesions will be seen. I will show you image. Okay, you need to identify. Second thing, BB type of leprosy, you will see inverted saucer-shaped appearance. Second thing, you will see geographical lesions. Okay, that you will see in the BB type of leprosy. Okay, in details you will study in micro as well. Okay, so can you identify which lesion is this? Can you see? This is a lesion, and around the lesion there are other lesions. This is known as satellite lesion. Okay, this is a satellite lesion, and satellite lesion is a feature of, this is how the question is coming. Satellite lesion is a feature of, answer, which type of leprosy? Look here guys, satellite lesion is a type of BT type of leprosy. Second thing, this one is your inverted saucer shape appearance, or you can say geographical lesion. This will be seen in BB type of leprosy. कौन से में दिखेगा? BB type of leprosy. So you need to identify according to the pictures. Okay, this thing, leonine facies. This thing is known as leonine facies. This is seen in lepromatous leprosy. Okay, and what is this organism known as? What is the name of this organism? Anyone? Remember guys, this is 9-banded armadillo. This is a 9-banded armadillo. Okay, 9-banded armadillo. Where do we use it? We will use it for the culture of lepra, Mycobacterium lepra, because it does not follow Koch postulate. What is Koch postulate? Remember, just listen. Koch postulate is Robert Koch said every organism will grow in a culture media, but Mycobacterium lepra does not grow in a culture media. So we need to grow it in a 9-banded armadillo. That is the Koch postulate. Okay. In India, there is no armadillo, so we grow it in the footpad of new suckling mice, right? Alright, till now we are done with the infections part. Okay, let's start with the ulcers. This is very important guys, because repeatedly question has been asked from this, from derma per se, the question has been asked from this, right? So first thing, you need to identify the different type of ulcers that we are having. Okay, in case if you are sitting in an OPD, then also it will be helpful for you to identify these types of ulcers. Okay, you will look and then you can easily identify. Just be with me with full concentration. for like 5 to 7 minutes and we will complete it, right? So ulcers, okay. There are multiple types of ulcers. First one is your herpes simplex virus, HSV. Okay, HSV 1 or 2, 1 will be above the waist, 2 will be below the waist, that you know. Second thing is your chancroid. Okay, chancroid will be due to Haemophilus ducreyi. Okay, chancroid किसकी वजह से होगा? That is due to Haemophilus ducreyi. Third thing will be syphilis. Syphilis is due to what is the causative organism? That is your Trypanosoma pallidum. Remember guys, Trypanosoma pallidum also does not follow Koch postulate. Okay, it will also not grow. Okay, it is a spirochete, you all know that. Okay, next one is your donovenosis. Donovenosis is caused by Klebsiella granulomatis. What is the causative organism? Klebsiella granulomatis. And the last one is lymphogranuloma venerum, that is caused by chlamydia. L1, L2, L3 strains होते हैं. L2 is the most common. Okay, L2 is the most common strain that will be causing LGV, right? So this is, you should remember, incubation period 9 to 90 days for syphilis, and donovenosis you should remember for 30 days. Now, how you will identify the ulcer? Can anyone tell me? Just look at the ulcers. Okay. Can anyone tell me which is this ulcer? Just by looking at the ulcer. Can you tell me which is this ulcer? Okay, just be with me and then after that you can easily identify. Okay, just look here. First thing, in the question we need to look for the pain. Okay, if the ulcer is painless, if the ulcer is painful, there can be only two possibilities. If the ulcer is painful, there can be only two possibilities. First thing, it can be ulcer of herpes simplex virus. Second thing, it can be ulcer of chancroid, right? First thing, it can be ulcer of HSV, or second thing will be chancroid. In syphilis, the ulcer is known as chancre. Okay, in syphilis, the ulcer is known as chancre. Remember, chancre, you can remember like chancre is painless. Chancre ko pain nahi hota. Okay, painful will be chancroid. Okay, so there are only two ulcers that will be painful. First one is your HSV, second one is your chancroid. Are we clear? These three will be ruled out. Syphilis, donovenosis and LGV will be ruled out. What is important about LGV? Remember guys, lymphogranuloma venerum ulcer is a transient ulcer. Very important. It is a transient ulcer, so you won't see ulcer. Okay, you will not find ulcer. Okay, you will find only buboes. Okay. Second thing, you need to look for edges. How you will differentiate between these painful ulcers? Okay. These painful, both of them are painful, then you will look for the edges. If the edges are undermined, that means it is a Haemophilus ducreyi infection. If the edges are undermined, it is a Haemophilus ducreyi. Okay. Lymphadenopathy, here will be bilateral, here will be unilateral. Okay. Ulcer will be multiple. Remember guys, the meaning of herpes or meaning of herpetiform is multiple. Okay. So here you will see multiple, herpes matlab multiple grouped vesicle with polycyclic erosion. Okay, this is a characteristic feature of herpes. Okay, you will see multiple grouped vesicle with polycyclic erosion. This is herpes का मतलब क्या होता है? The meaning of herpes is grouped. Okay, herpes zoster. What is the meaning of zoster? Zoster means along a nerve segment. Okay, if you understand the meaning, you will easily identify. Herpes matlab there will be grouped vesicles. Okay, so here you will see the ulcer is having grouped vesicles. It is a painful ulcer. Okay, edges are not undermined. Okay, here the edges are undermined. You can see these are undermined edges. Okay, undermined edges. Ulcers will be multiple ulcers are there. Here multiple, here multiple. Okay, here also multiple ulcers and edges are undermined. If edges are undermined, it is Haemophilus ducreyi. If polycyclic erosion is there, it is herpes simplex virus. Easy, right? Next thing, let's talk about painless ulcer. Okay, painless ulcer, these three: syphilis, donovenosis and LGV. Okay, in syphilis, just remember this term. It will help you solve most of the questions. In question, if it is written shorty or rubbery, that means it is a syphilis. Okay, that means it is a syphilis. Okay, single ulcer will be there. This is a single painless, you already know this is a single painless ulcer with shorty or rubbery. If it is written shorty or rubbery, that will be your syphilis. You can easily identify. Again, if you don't remember, it's okay, no problem. You will look for donovenosis. Just remember, in donovenosis the ulcer will be single and beefy red. Okay, the ulcer will be single and beefy red, and it will bleed on touch. Whenever you will try to touch the ulcer, it will bleed. Okay, in LGV you will not find any ulcer. Okay, so it will be easy for you. Okay, so here the ulcer will be beefy red ulcer, that will bleed on touch. Okay, so easy to identify all the ulcers. Okay, in OPD, if you are sitting in OPD, whenever you will see the patient, you will easily identify whether the patient is having which kind of ulcers. Okay, and according to the ulcers we will study about the treatment part. Okay, so that will be easy for you to understand. Okay, all right, let's move. For treatment purpose, for example, let's say we are having STD clinics as well now, but we are having STD kits. Okay, and on the basis of those kits we are giving the treatment. Okay, the patient is coming to me, let's say if I'm sitting in a OPD, the patient is coming to me and he will be like, sir, I am having urethral discharge. Okay, I am having urethral discharge, what should I take? Okay, so what I will see in urethral discharge, there are two possibilities. First one, either it can be a gonococcal infection. क्या हो सकता है? It can be a gonococcal infection, either it can be non-gonococcal infection. Okay, gonococcal और non-gonococcal हो सकते हैं. If it is a gonococcal infection, there will be purulent discharge. Okay, bacteria will release what? Gonococcal infection will release purulent discharge. Okay, white color ka purulent discharge will be there. If it is not white, it is mucoid. That means it is not a gonococcal ulcer. Okay, in both the scenarios, I will not be able to identify. I just want to treat my patient. Okay, so how I will treat? I will not go into further diagnosis, deep diagnosis. What I will do, I will give the drug for the both the treatment. Okay, so how I will treat the patient for gonococcal, broad spectrum third generation cephalosporin, that is your ceftriaxone, along with macrolide, that is your azithromycin I can give. Here in the second case for chlamydia, I can give doxycycline along with the azithromycin. So I prepared a kit. Okay, that is your kit number 1. Kit number 1 will include what? It will include azithromycin 1 gram along with cefexime 400 mg. Cefexime is also a cefexime. Remember, cefexime is a second generation cephalosporin. Okay, it should be third, but it is a second generation cephalosporin. Just remember this. Okay, so this is also a broad spectrum antibiotic. So this is the kit number 1. If you are having urethral discharge, just give the kit. Okay, kit number 1, that is great. What will happen? Whatever may be the pathology will be cleared, right? Second thing will be vaginal discharge. If the patient is coming to me and she will be like, I'm having vaginal discharge, there are multiple possibilities. First one, either it can be a fungal infection, right? It can be due to candida, right? First thing is candidal infection. Second thing, it can be due to trichomonas or bacterial vaginosis. Okay, if it is a fungal infection, what I need to do, I need to give a drug that is antifungal drug, right? That is your fluconazole. If it is a bacterial infection or parasitic infection, what I need to do, protozoal infection, what I need to do, I need to give anti-amoebic drug. This is a anti-amoebic drug, right? Metronidazole or metronidazole. Okay, so in short, if I give both the drug, if I give fluconazole along with sakinidazole, okay, fluconazole is a antifungal drug and sakinidazole is a it is like metronidazole, anti-amoebic drug. Okay, if I combine both the drug, that is kind of a fixed drug combination. Okay, if I combine both the drug, what will happen? Whatever may be the discharge, whatever may be the causative organism, it will be treated, right? So my purpose is to treat the vaginal discharge and it will be treated. Okay, so I can use kit number 2, that is green colored kit. I will show you all the kits. Just try to understand the concept, because if you know the concept, you can easily identify and you can easily derive the things. Okay, third thing will be genital ulcers. Okay, if there are genital ulcers and they are non-herpetic, I told you the meaning of herpes. Herpes means it is in the group. Okay, if they are non-herpetic, it could be syphilis, yeah, single ulcer, it could be donovenosis, okay, it could be chancroid. What I will do, all of these three are bacterial infection. What I need to do, I can give penicillin or azithromycin. Okay, the drug of choice for syphilis is penicillin. We are having primary, secondary, tertiary syphilis and early latent and late latent. and then neurosyphilis. Okay, all of them the drug of choice will be penicillin, so I need to give the penicillin. Okay, along with for donovenosis and chancroid, the drug of choice will be azithromycin, that is macrolide. Okay, so I can give kit number 3. Kit number 3 will be constituting penicillin along with azithromycin. Remember, this question is coming from PSM part as well as your derma part. Okay, so this is important. But if the patient is allergic to penicillin, and if the patient might be having like syphilis infection, what we need to do, we need to change the drug. Okay, we need to change the drug to doxycycline. Okay, what I need to do, I need to give him doxycycline in place of penicillin along with the azithromycin. Same story. Okay, अगर कोई पेशेंट आता है, पेशेंट इज कमिंग टू मी, ही विल से सर आई एम हैविंग जेनाइटल अल्सर्स एंड इट इज़ नॉन herpetic, it is non grouped, what I need to take, but I have some penicillin allergy, so please try to give me drug which is not a penicillin derivative. So what I will give him kit number 4, right? Next one is your herpetic. Herpetic is a viral infection, so if herpetic ulcer is there, I need to give acyclovir, that is 400 mg TDS into 7 days, right? Next thing is your pelvic inflammatory diseases. If there are any kind of pelvic inflammatory diseases, that means the patient is having pain in the lower abdomen part. Okay, in lower abdomen part, if there is a pain, there can be two causes. Either it can be bacterial infection, either it can be a amoebic infection. Okay, so for bacterial infection, I will be giving cefaxime along with the metronidazole, right? So that is your kit number 6. And the last one is for the buboes. Buboes are your lymph nodes, that is your doxycycline along with the azithromycin. So these are your 7 kits, and I think you guys understood now why we are giving these combinations. Okay, these are your 7 kits. Okay, so this is what is written over here. I simplified it. If there is urethral, anorectal or cervical discharge, first thing gray, second thing green color, you should remember. First one is gray, second one is green. You can remember the Raynaud's sequence. One more question, Raynaud's phenomena sequence, that is white, blue and red. I will show you the image. You can remember like that as well. White, blue and red, and then yellow and black. Okay, so this is the color coding. Drugs will be same. Ag, cefaxime. Why we are giving, you should understand that. Okay, you should remember that. So we are done with the this one, STDs and all the genital ulcers. Are we clear till here? Next one is your vesicobullous disorders. I have told you in the primary lesions, what is the meaning of vesicle? What is the meaning of vesicle? If it is a fluid filled lesion less than 0.5 centimeter, right? That is a vesicle. What is the meaning of bullous? I told you what is bulla. More than 1 centimeter clear fluid lesion is known as bulla. Okay, so we are having 2 types of disorders. First one is your, mainly 2 types. First one is your pemphigus, another one is pemphigoid. Now try to understand what is the meaning of pemphigus and what is the meaning of pemphigoid, right? So pemphigus, you can remember with the name as well, S is there, so that will be superficial. Okay, superficial. Here in pemphigoid there is a D, that means it is a deep. It will be deep. Okay, let's talk about antibodies. I have told you 2 acanthocytes. Acanthocytes are skin cells, epidermal cells. Okay, 2 acanthocytes are bind together with the help of desmosomes. Okay, these are your desmosomes. If these desmosomes are broken, then what will happen? Your skin will rupture. For example, this is my epidermis. Let's say this is my epidermis, and multiple keratinocytes are there, right? They are bind together in the stratum spinosum with the help of desmosomes. The function of desmosome is to bind 2 keratinocytes. Now what will happen if there is no desmosomes? If there is antibody against desmosomes, what will happen? These keratinocytes will be separated, and if these keratinocytes will be separated, what will happen? There will be separation on the skin as well, right? So that will lead to formation of pemphigus. Nothing is there, nothing fancy, that is called as pemphigus, right? And this is how it will look. What is happening over there? Epidermis is stretched out because of desmoglein. There is a defect in desmosomes, right? So 2 keratinocytes will be fell apart, and that will lead to formation of pemphigus. Okay, So what are the antibodies that are formed in the pemphigus group of disorders? What are the antibodies that are formed in the pemphigus group of disorders? Look here, guys. In pemphigus, the antibodies are formed against desmosomes. Okay, desmosomes or desmogleins, right? Here the antibodies are formed against desmoglein. Okay, desmosomes. Which one? Desmoglein. Now what will happen? There will be bulla formation. Okay, there will be bulla formation. That means there will be fluid accumulating inside. Okay, that bulla will be flaccid bulla. Remember this word, guys. This will help you to solve multiple questions. Just you need to look for flaccid or tense. Okay, I will tell you how. Just remember. Look here, guys. Okay, second thing, in pemphigoid what will happen? It is a deep blister. Okay, pemphigoid is a deep blister. Okay, look here, it is a deep blister. It is looking tense, right? I will tell you how. Okay, here the separation will be here the IgG will be formed against. Remember I told you about the dermoepidermal junction. There are bullous BPAG1 and BPAG2. Here IgG are formed against BPAG1 or BPAG2. Okay, IgG is formed against BPAG1 or BPAG2, more commonly BPAG2. Okay, then what will happen? Suppose these are your two keratinocytes. They are bind together with the help of desmosomes. But I told you these keratinocytes are bind with the basement membrane with the help of hemidesmosomes. Okay, with the help of hemidesmosome protein. Now the rupture will be here. Be here. So it will be a deep bulla, and the problem will be in the basement membrane zone. So the bulla will be tense. Okay, flaccid bulla means they will be easily ruptured. When you try to rupture a flaccid bulla, it will be easily ruptured. But in cases of pemphigoid, what will happen? The bulla will be deep, bulla will be tense. Okay, so in question, whenever you will see tense bulla, the answer will be pemphigoid. Whenever you see superficial, whenever you see pemphigus, the answer will be flaccid bulla. Okay, this is what you should remember. Okay, for the exam purpose. Now let's talk about pemphigus group of disorder. Two things you should remember. First one is your pemphigus foliaceus, second one is your pemphigus vulgaris. Look here, guys. First thing is your pemphigus foliaceus. You can remember F for first. I have told you the antibodies are against desmoglein 1. Okay, here the antibodies are against desmoglein 3. You can remember like that. Okay, this will be in the stratum spinosum, and this will be a suprabasal spinosum. After spinosum there will be basal. Okay, so the split the bulla will be suprabasal bulla. Okay, here it will be in the stratum granulosum. So we can call it, granulosum is just below the corneum, right? So we can call it subcorneal bulla, right? The most important thing, it will affect buccal mucosa as well. Okay, buccal mucosa as well. You can remember the pemphigus group of disorder with the help of a mnemonic, that is MINAR. Okay, MINAR. You can remember like that. There will be R for row of tombstone appearance. I will tell you how. Okay, mucosal involvement will be there. These will be intraepidermal bullae, Nikolsky positive, and there will be acanthocytes. Okay, if desmosomes are gone, there will be acanthocytes. Simple cells in the stratum spinosum are known as acanthocytes, right? So we have seen till here. Yeah, this one is your Nikolsky sign. What is Nikolsky sign? Suppose if there is a bulla, I will try to pressurize it from a tangential pressure. अगर मैं tangential pressure लगाऊंगा, that is known as Nikolsky sign. And if I try to put a perpendicular pressure, then that is known as Abscess-Hansen sign. On histology, we will see acanthocytes. Acanthocytes are basically keratinocytes of the stratum spinosum. These are the keratinocytes of the stratum spinosum, and that will give a characteristic appearance that is known as, look here guys, that is known as row of tombstone appearance. कौन सी appearance बोलेंगे इसको? Row of tombstone appearance. This is known as row of tombstone appearance. All right. So this is your histology part. In DIF, what we will see? In DIF, we will see fishnet-like pattern. Fishnet-like pattern. In DIF, we will see fishnet-like pattern. Okay. And the treatment will be steroids along with cyclophosphamide, rituximab we can use. Okay. So this is all about the pemphigus part. Let's talk about the pemphigoid part. Okay. What is pemphigoid? Bullous pemphigoid. I have told you about the antigen. Bullous pemphigoid. You can remember like BPAG. BP मतलब याद रख लो कि bullous है. BPAG1 और BPAG2. Okay. There will be linear IgG deposition. Okay. These images are very important. Just try to understand. Here what is happening, guys? Just try to understand. Either you can remember like fishnet pattern will be seen in pemphigus group of disorders. Either you can remember like what is happening here. IgG antibodies are formed. IgG antibodies are formed and they are deposited here. They are deposited outside the cells. Okay, desmoglein nahi hai. So what is happening? There is a IgG antibodies formed and they are deposited here, and we are looking for that antibodies. Okay, that is your IgG. In bullous pemphigoid, what will happen? I have told you this is an intraepidermal split, and here I have told you the split will be in the basement membrane zone. Okay, so here will be epidermis, then this is your basement membrane zone, and then there will be dermis. So what will happen? Antibodies will be coming and they will be settling here, right? Which antibodies are they? They are IgG against BPAG2 or BPAG1. Are you clear till now? Okay, so IgG antibodies are formed against BPAG1 or 2. That will be giving rise to a linear pattern. Okay, linear pattern. Linear IgG deposition on the basement membrane zone. Okay, what kind of bulla do you see? You will see a tense bulla. Okay, yeah, and the treatment will be steroids. How you will treat? You will treat with the help of steroids. Okay, so that is your bullous pemphigoid. Third one is your linear IgA disease. In linear IgA disease, what will happen? Again, there is deposition of deposition on the basement membrane zone. How you will differentiate? Here in bullous pemphigoid, the antibody are IgG, but in linear IgA disease, the antibodies are IgA. They are deposited on the basement membrane zone. Both of them are same, but you will identify with the help of this antibody. Okay. This kind of question will not come, but if the image is coming along with the different clues, they will give you. Okay, so please just do concentrate here. Okay, next one is your what kind of appearance you will see in linear IgA disease. That is your string of pearl appearance. क्या बोलेंगे इसको? String of pearl appearance. This is your string of pearl appearance. Last one is your dermatitis herpetiformis. Herpetiformis means again there is a grouped vesicle. Okay, in dermatitis herpetiformis, what you will see? You will see grouped vesicle on the extensor surface. Okay, बाहर वाली जो surface होती है वहाँ पर क्या मिलेगी? You will see grouped vesicle. That is your dermatitis herpetiformis. Dermatitis herpetiformis is associated with celiac disease. कौन से disease से association होगा? They are generally associated with celiac disease. Okay, what are the antibodies that you should remember? What are the HLA? These are your HLA-B8, DQ2 or DR3. HLA-B8, DQ2 or DR3. Okay, what are the antibodies? You will see in three type of antibodies in celiac disease as well. First thing is your anti-endomysial antibody. Second thing is your anti-gliadin antibody, and third thing is your anti-TTG. Okay, anti-TTG. These are for celiac disease as well. Okay, so this is dermatitis herpetiformis, always mostly associated with the celiac disease. Okay, here you will see papillary tip microabscess. Remember, we have seen in this third slide, we have seen the papillary tip microabscess. So here what is happening? This is your retiridges, and whatever is going into the epidermis, the part of dermis that is going into the epidermis, that is known as papillary dermis, right? So in papillary dermis, we are seeing some microabscess, some deposition, that is known as papillary tip microabscess. abscess, that is known as papillary tip micro abscess. Okay, so there is IgA deposition. Again, there is IgA deposition in the papillary tip micro abscess. Okay, the drug of choice will be dapsone and the treatment of choice will be avoid bro. What is bro? That is your barley, rye, oats and wheats. Okay, because it is a celiac disease. Okay, clear? So 4 things we need to remember. First one is your pemphigus, second one is your bullous pemphigoid, third one is your linear IgA disease, and the last one is your dermatitis herpetiformis. These are the most important question has been asked from this in the previous exams. Okay, let's talk about some next disorders. These are your pigmentary disorders. इनको क्या बोलेंगे? पिगमेंट्री डिसऑर्डर्स बोलेंगे. देन वी विल एंड अप विद द मिसलेनियस डिसऑर्डर्स. ओके, सो पिगमेंट्री डिसऑर्डर्स, लेट्स स्टार्ट वन बाय वन. फर्स्ट इमेज, प्लीज ट्राई टू आंसर. व्हाट इज दिस इमेज? प्लीज ट्राई टू आंसर. व्हाट इज दिस इमेज? till now I will tell about the second thing. This is known as Mongolian spot. Mongolian spot कहाँ देखेंगे? You will see on the back side of the trunk. Okay, and कितने टाइम में रिजॉल्व हो जाता है ये? जनरली विद इन ए ईयर. This will be resolved within a year, right? This is known as nevus of Ota. Remember, O for ophthalmic. Okay, you can remember like that. O for ophthalmic, and this is ophthalmic bluish discoloration. Okay, bluish discoloration. So this is a nevus of Ota. You should identify the images. Okay, one more thing is there, that is known as nevus of Ito or Ito. Okay, you can remember like that. कुछ लोग होते हैं ईट उठाते हैं, so they carry their eat on shoulders, right? So it will be on the shoulder. Okay, and if nevus मतलब क्या होता है? Nevus मतलब change in the color, right? If we are having nevus along with hairs, that is known as Baker's nevus. क्या बोलेंगे इसको? Baker's nevus. What do we call it? That is known as Baker's nevus. Okay, if the nevus is there along with the hair follicles. Okay, here we are having hair follicles, right? And this one is your Acanthosis nigricans. This one is your Acanthosis nigricans. Acanthosis means thickening of stratum spinosum. Acanthosis का मतलब ही क्या होता है? The meaning of acanthosis is thickening of stratum spinosum. Very good, Kush. Very good. Love heal grow. Okay, so this is your melasma. Increase in brownish discoloration. क्यों होता है ये? This is due to excessive melanin deposition. What will happen? Excessive melanin deposition will lead to this thing. Okay, that is your Acanthosis nigricans. Okay, Acanthosis nigricans is indicated of क्या बताता है ये? It is a marker for obesity. Okay, it will tell about the obesity. It will tell about diabetes mellitus type 2, and it will also indicate us about the gastric adenocarcinoma. Okay, gastric adenocarcinoma, internal malignancy. Okay, adenocarcinoma. It will also tell us about the internal malignancy. Okay, these are your miscellaneous topics. Let's talk one by one. First one is your try to identify that is your pyabaldism. Okay, what will happen? There will be defect in the melanocyte. It is a autosomal dominant condition. कैसी condition है? This is a autosomal dominant condition, right? Next one is your vitiligo. Okay, vitiligo, there will be also absent of melanocytes. Okay, melanocytes, what will happen? There will be no melanosomes, there will be no melanin in certain parts of the skin. Okay, it could be localized, it could be generalized. Okay, localized क्या होगा? Particular जगह पे. For example, let's say that is your focal vitiligo. Okay, second one is your along a nerve segment, so that will be segmental vitiligo. Okay, second thing will be generalized. Generalized means that will be present on the both the parts. Okay, so look here, that is your acrofacial. Okay, on the face, on the extremities. Okay, here will be vitiligo vulgaris. Vulgaris is a common term. The meaning of vulgaris is common, so that is the most common vitiligo. Okay, and universal, there will be all the mostly skin structures that will be under the vitiligo. Okay, this is your melanin deficiency. Diagnosis is albinism. That is due to defect in melanin synthesis. Why melanin is not synthesized? Because of absence of tyrosinase enzyme. Okay, tyrosinase will convert into melanin, right? Melanin, dopamine, epinephrine, norepinephrine, all those are formed from tyrosine, right? All those are formed from tyrosine. So if there is absence of tyrosinase enzyme, what will happen? There will be absent synthesis of melanin, and ultimately leading to a condition known as albinism, right? Albinism. Clear? Yeah, this one is parabeldism. You know Indira Gandhi. You will see white forelock. This is the white forelock, right? Next one is your this one is your cerebriform nucleus. Or Sézary cells. This is characteristic feature of cutaneous T cell lymphoma. Also known as mycosis fungoides. We have seen mycosis fungoides. It is a cutaneous T cell lymphoma. Okay, उसी का ये characteristic feature है. This is your Harlequin baby. Can you tell me the gene which is involved? That is your anyone? आपका 1-2 ABCA 1-2, right? Okay, this one is your patch test for allergy. Okay, for contact for dermatitis, that is your patch test. Reading will be taken, that was a question, 48 or 96 hours. If both the options are given, please go for 96 hours. Okay, please go for 96 hours, then second option will be 48 hours. Okay, because this is the type 4 hypersensitivity. Okay, type 4 hypersensitivity. So readings will be taken on the 4th day, followed by 3rd day. Okay, this is herpes zoster. I told you the meaning of herpes is grouped. Zoster means along a nerve segment. Zoster का मतलब क्या होता है? The meaning of zoster is along a nerve segment. So that is your herpes zoster. What is the treatment? Treatment will be again acyclovir. Treatment में क्या देंगे? Acyclovir 800 milligram for 5 times a day into 7 days. Okay, yeah, okay, into 7 days. What is normal? Yes, it is normal at birth, right? Next one is your dermatomyositis. What is dermatomyositis? इसके नाम में देखो, look at here. Derma, what is the meaning of derma? Derma means skin, so it will be involving skin. Myo means muscle, and it will be involving muscle, and itis means inflammation. So it will be inflammation of skin. Okay, muscle will be affected here also. So what are the signs that you will see? First thing is your this edema. ठीक है, this edema, erythematous edema, that is known as heliotrope rash. क्या बोलेंगे इसको? Heliotrope rash. That was a image based question. Okay, second thing, where we wear shawl, जहाँ shawl ओढ़ते हैं, that is your shawl sign. Okay, you will see erythema over there, that is your shawl sign. And third one, you will see papules on metacarpopharyngeal joints, that is your Gottron's papules. क्या बोलेंगे इनको? Gottron's papules. कौन सा papules बोलेंगे? Gottron's papules. Okay, and there will be mechanic hand क्यों बोलेंगे? There will be thickening of stratum corneum. Okay, the superficial layer that we have seen, that is thickened, that is known as thickening of stratum corneum, that is known as mechanic hand. So these are all the features of dermatomyositis. These are all the features of dermatomyositis. myositis. Yeah, this is known as Gottron's papule. Okay, next one is your staphylococcal scalded skin syndrome. Okay, staphylococcal scalded skin syndrome, there will be there will be formation of toxin, that is exfoliative toxin type 1 or epidermolytic toxin type 1. Okay, exfoliative or epidermolytic toxin that will lead to epidermolysis or breaking of the skin. Okay, that is your SSS, that is due to bacterial infection. Okay, staphylococcus. Toxic epidermal necrolysis, we call it 10 when it is more than it is more than 30% of the area which is damaged, right? We call it 10. And it is due to certain things, like for example NSAIDs, for example like drugs like that we use in psychiatric disorders like lamotrigine. Okay, lamotrigine and all those drugs, phenytoin, that can lead to toxic epidermolysis necrosis. Okay, one more thing is there, that is your Stevens-Johnson syndrome. एक और होता है, that is your Stevens-Johnson syndrome, but here the damage will be approximately less than 10%. Okay, damage will be less than 10% of the skin. If it is less than 10%, that will be Stevens-Johnson syndrome. If it is more than 30%, that will be toxic epidermal necrolysis, right? And if it is between these two, that is known as overlap, right? That is known as overlap. There will be severe mucocutaneous rashes will be seen, right? All right. Are we done till here? Okay, look here guys, just look here and please try to identify the skin cancer. Okay, first one is your basal cell carcinoma. Basal cell carcinoma is also known as rodent ulcer. What do we call it? Rodent ulcer. और कहाँ पर होगा? Mostly teardrop signs. कहाँ पर teardrop जहाँ थे? Mostly teardrop region. Okay, that is your basal cell carcinoma. It is most easy to treat. We can just remove it out and it will be treated. Second one is your squamous cell carcinoma. Squamous cell carcinoma, most common site will be hand. Right? There will be firm red nodule that will be seen. Okay, that is your squamous cell carcinoma. Disc keratosis will be seen here. Okay, this will also be treated easily if it is detected early in the life, but they can be spread. Third one is your melanoma. You should remember, that is your melanoma. Okay, we need to differentiate melanoma between with a simple mole. Okay, we will see how to differentiate a melanoma and a simple mole. That is also dangerous, right? Next thing is your, look here, this is your erythematous violaceous papules. Okay, erythematous violaceous lesions seen in lupus pernio or also known as sarcoidosis. Look here guys, these are the lesions which are not sparing the nasolabial fold. Okay, इसका differential diagnosis क्या होगा? What will be the differential diagnosis? That is your SLE. In SLE, the nasolabial folds are spared. Look here guys, the nasolabial folds are spared. In lupus pernio, the nasolabial folds are not spared, right? I have told you about the Raynaud's disease and Raynaud's phenomena. Raynaud's phenomena, there will be discoloration. First will be white, second will be blue, and third will be red. Okay, white is due to there will be stasis of blood. What will happen? There will be no supply of blood, then it will lead to white in color. Then there will be ischemia leading to bluish color because of there will be ischemia will leading to the bluish color, and ultimately what will happen? There will be normalization of the supply that will lead to again red color. Okay, so that will be the sequence. कब होगा? How it will happen? Due to hot or cold phenomena. मतलब if you are having extreme cold or extreme hot, then it will happen, right? And it is associated with multiple diseases. Raynaud's disease is a different thing. Raynaud's phenomena is associated with multiple diseases. All right. Let's talk about pyoderma gangrenosum. It was a question asked back then. Pyoderma gangrenosum is associated with inflammatory bowel diseases, right? But what which one is the most common association? The most common association is with the ulcerative colitis. Most common association is with the ulcerative colitis. Okay. Next one is your sclerodactyly. Sclerodactyly, there will be pitting with scarring. You can see there will be pitting along with the scarring of ulcers. Okay. Now let's talk about this image. This one is your xeroderma pigmentosa. What is xeroderma? Zero means, what is the meaning of zero? The meaning of zero will be dryness. Okay, so there will be dryness. Xeroderma pigmentosa, there will be dryness, and it is a nucleotide. This is a nucleotide excision repair defect. This is a nucleotide excision repair defect that we will see. The patient cannot go out in the sun. Okay, if the patient will go out in the sun, the patient's skin will be burnt. Okay, look here. This is your xeroderma pigmentosa. Okay, next thing, let's talk about some dermatitis. Okay, some dermatitis. Look here, guys. Here you are seeing some dermatitis, and this dermatitis due to nickel. Okay, what is the causative agent? Nickel. Because like female wear anklets. क्या पहनती female? Anklets in the legs, and those anklets will be having nickel. Artifacts will be having nickel, and that will lead to dermatitis. That is known as allergic or contact dermatitis. Okay, allergic or contact dermatitis is which type of hypersensitivity? Again, it is a type 4 hypersensitivity. Okay, but atopic dermatitis or hay fever, these are your type 1 hypersensitivity. These are your type 1 hypersensitivity. Okay, there will be arrhythmia. In atopic dermatitis, there will be arrhythmia. Okay, क्या मिलेगा यहाँ पर? Arrhythmia और edematous lesions मिलेंगे. Edematous. Okay, this is your irritant contact dermatitis. Irritant contact dermatitis is maybe due to like detergent, maybe due to detergent. Okay, because of use of detergent, it will lead to irritant contact dermatitis. Okay, look here, guys. This is your astotic or xerotic dermatitis, or also known as winter eczema. This is due to dryness, and this lesion is known as nummular dermatitis. Nummular, what is the meaning of nummular? Nummular means coin shaped lesions. Okay, the lesions will be coin shaped. So basically these are all the dermatitis. Neurodermatitis, along a nerve segment. Okay, neurodermatitis will be along a nerve segment. Okay, and this one is your perioral dermatitis. So dermatitis is nothing but your inflammation of the skin, right? Seborrheic dermatitis, you will see greasy like scaling. Okay, this is your, if there are hairs, then you can see greasy scaling, but this is your seborrheic dermatitis. Hindi mein bolte na, we call it like dandruff. Okay, cradle cap appearance we will see in the children. Cradle cap appearance we will see in the children. That is also a type of seborrheic dermatitis. That is also a type of seborrheic dermatitis, right? Here you can see the flax. Okay, you can see the flax of dandruff. Flax of dandruff you can see, right? And this test, again, this is a patch test. Okay, patch test, and this is a type 4 hypersensitivity. And how when we will take the reading? Again, 96 hours, more than 48 hours, right? And these one are the allergens. Okay, these are some allergens that you need to remember. First one is your nickel. Just remember few out of them. Nickel will be present in your artificial jewelries. Okay, chromium or potassium dichromate, they are present in your cement and paint. Parthenium is also known as Congress grass. That is the most common allergen that is present for dermatitis as well as asthma and hay fever, right? This is your PPD is present in your hair dye. Latex and rubber will be in the gloves. Neomycin, most common topical medicine that will be causing dermatitis, and para-tertiary butyl phenol, that is present in your bindi, right? This is important. There is a rule for diagnosis of melanoma, that is your ABCDE. How we will differentiate? I told you how we will differentiate between a mole and a melanoma. Okay, so there will be asymmetry. It will be asymmetrical. B for borders. This was a question. This was a previous year question. B for border. Okay. C for there will be color change. It will be changing the color. D for diameter. It will be more in size, more than 6 mm. Okay, and it will be evolving, or it will be changing in the size, right? So that is all about the melanoma, right? That is all about the melanoma, and we are we are done with the session, guys, and I hope you guys understood so many things now. So please try to revise it before the exam. And yeah, just a moment. I think we have completed everything. So we are done with the basics. We have done with the skin appendages like your nails, hairs, and skin, nails, hairs, and glands. Then we have done with the papillosquamous disorders, infections, all completed. STDs, vesicular disorders, pigmentary disorders, miscellaneous topics. So we are done with everything, guys. Thank you so much for your patience. If you are having any doubts, you can always reach out to us on any platform, Instagram, wherever you want. Okay, so thank you so much, guys. Have a good day. Bye. If you are having any doubts, you can ask. I will send the PDF. Thank you, Love Heal Grow. Thank you, Selva. Thank you, Kush. Goodbye.